Defensive. Mic. Check. Okay. Check. Not working. Check. A warm welcome to all our delegates and respected professor, both in person and online. We are honored by your presence and excited for the knowledge, insights, and connections this national conference on rTMS 360-degree will inspire. I now request our beloved HOD, Dr. Priya Shivashankar, to give a welcome address.
Good morning. Good morning, everyone. I sincerely apologize for my lack in height. Department of Psychiatry is very excited to welcome all delegates. We have delegates coming in here from various parts of Chennai, medical students, private practitioners, consultants from other parts of Tamil Nadu, from nearby states like Andhra Pradesh, Kerala, Karnataka, Telangana, as well as from not so nearby places like Mumbai, Meerut, Andaman Nicobar Islands, Jammu Kashmir. One person has logged in from Scotland. A very hearty welcome to all of you. We are thrilled to be organizing this conference, rTMS 360 degrees. This will be a great opportunity for all delegates to learn skills, learn about the clinical applications, as well as explore various research applications for this. Today, we'll be discussing various topics, starting right from the basic principles of rTMS, from neurophysiological effects to clinical applications. Dr. Shubham will be talking to us about the various FDA protocols and the evidence base for them. Along with that, there is higher level learning also. Neuronavigation increases the accuracy of rTMS by enhancing the accuracy with the help of neuroimaging data. And apart from the mundane, we have a senior psychiatrist talking to us about the extended applications of rTMS. Our faculty is varied as well. We have Professor Rohit Verma, we have Dr. Rahul Ganesh, we have Dr. Shubham Narnoli and Dr. Murugappan. They have been using rTMS for a long period of time and they are considered experts in this field. This conference will also give all the people interested in rTMS a unique opportunity to network, stay connected. I encourage all delegates to have active participation, ask questions, participate in the discussion, share their own knowledge and experience so that we can all have an enhanced learning experience. Wishing everyone an insightful and engaging learning experience at this conference, rTMS. I now hand over the stage to the compares for the morning, Dr. Reshma and Dr. Minal. Thank you.
Thank you, ma'am. Now let us begin with the academic proceedings. Now I invite Dr. Sabari Sridhar to chair the first session on the topic rTMS Demystified from Neurophysiological Principles to Clinical Effects. It is my pleasure to introduce Dr. Sabari Sridhar, an accomplished psychiatrist and academic leader, currently serving as the professor and HOD at the Department of Psychiatry at Sri Ramachandra Institute of Higher Education and Research. Dr. Sabari Sridhar has over a decade of clinical, academic, and research experience with over various publications and extensive involvement in postgraduate and PhD mentorship. His areas of interest include addiction medicine, child and adolescent psychiatry, and anxiety disorders, and he is a driving force behind numerous academic and clinical initiatives in the field of mental health. Sir, over to you to introduce our speaker, Dr. Rahul Ganesh.
Very good morning. Very good morning to everyone. So it's my pleasure to chairing this session. I at the outset thank Dr. Priya and her team for inviting me to be part of this wonderful conference, rTMS 360-degree National Conference and Workshop. So they have curated this conference to a very well good 4 topics as well as good 2 hours, 3 hours of workshop, hands-on workshop. So I think people will be benefiting from whatever experts are going to give you the knowledge about all the things related to rTMS. So at the outset, we'll be starting the first session. It will be done by Dr. Rahul Ganesh. He is the Assistant Professor, Department of Psychiatry, JIPMER. He has completed his MD Psychiatry from AIIMS, New Delhi. His special areas of interest are child psychiatry, neuromodulation, and digital psychiatry. He's a Life Fellow of Indian Psychiatric Society, Indian Association of Child and Adolescent Psychiatry, Neuromodulation Society of India, and member of Indian Association of Social Psychiatry. He has many awards and recognitions. He has got the Best Paper Award for Indian Psychiatric Society Conference and Young Psychiatry Award in the Indian Association of Social Psychiatry Conference, and also got AIIMS Excellence in Research Award. He has many publications to his credit. Some of them like telepsychiatry during COVID-19 and celebrity suicide reporting, Nation Journal of Psychiatry. So uh, I think he'll be talking about the basic neurophysiology and the clinical applications of rTMS. So without much delay, I'll invite Rahul Ganesh to take over the stage. We are all eager to listen to your speech, sir. Please come. Thank you. Okay. We'll start with the presentation. I thank Balaji Medical College for inviting me for this lecture. And today we are going to learn from each other. It is like no one is expert here. rTMS is something new and unique. Though it is there for long duration of time, some things are coming up each and maybe every 6 months, or we will see once we are going through. So as we all know, neuromodulation, what is effective is ECT. And there is, till now, there is nothing comparable to ECT. But in psychiatry, what we are trying is, we are trying different non-invasive devices to be as comparable to ECT as we can say. So what exactly it is? We have different neurobrain stimulation techniques. It could be invasive, it could be non-invasive. So non-invasive is the one where electrodes are placed or magnetic coils are placed to modulate the brain activity. And invasive is the one where we are surgically implanting something and modulating the activity. Basically, there are numerous, and currently today's lecture will be focusing on rTMS, and I will be speaking about what exactly rTMS is, what are their effects, and how it is getting used. So basically, what is TMS? It is magnetic stimulation, right? So this is TMS, like Magneto is there. So he has control over his magnetic field, and through which he is controlling the electromagnetic induction and causing some effect, right? So desired effect. Like that, we can think. So rTMS is also such thing where it is a non-invasive brain stimulation technique which uses rapidly alternating magnetic field to induce small electric currents in the targeted area, and that produces an that induced current can either activates or inhibits the neuronal activity. So basically, this is rTMS, right? So when it came, like electrical stimulation of brain is there for a long duration of time. For example, encephalopathy were involved with ECT, and then there are multiple researchers who are trying to do without making the patient unconscious can be give electrical stimulation. So Merton and other his colleagues were trying this thing in 1980s, and they found that it is possible. Like we can stimulate a patient, we can produce motor evoked potential without even making the patient unconscious through electrical stimulation. So the same principle was tried by Baker and colleagues. What they did is they made a contactless non-invasive device which directly stimulates the motor cortex using a pulsed magnetic field. And this is the paper which says that it is possible to do it, and motor evoked potential can be demonstrated. And this is the game changer. After which multiple research came up, people started working on it. And what is the principle behind it? It basically works on Faraday's principle of electromagnetic induction, where when there is a changing electromagnetic field, it causes an induced current. Like this is the rapidly fluctuating current or electric pulse in the conductive coil or wiring, which in the wiring produces a magnetic field which is also fluctuating perpendicular to the coil, and that produces an electric current, secondary inducing current in the nearby conductor, which is the brain. And by using different pulses of different combinations, we have like low frequency, high frequency, theta burst, and everything. So basically, how it is working, the power of the magnetic, and we also should be aware that there is inverse Cube law, where the power of the magnetic field decreases exponentially when the distance from the original current increases. So when the magnetic field decreases, the amount of induced current that is getting stimulated will also decrease. And there are also other problems like the scamp and other extra issues which will prevent us stimulating the brain. So in the initial protocols, whatever there, we're actually focusing on only 2 or 3 centimeters of the brain. Currently, newer protocols have come up and it stimulates even deeper areas of the cortex. So the induced current through studies they have done whatever it is maximum in the Crohn region of the pre and postcentral gyrus. This is one study which is demonstrating that. So there are different mechanisms of how it works, right? So so what could be? One is axonal depolarization, which like TMS stimulates the neurons in the brain through depolarization of the myelinated axons. And but the propensity of the axon to get stimulated, it also depends on the spatial orientation and whether it is in the resting state or in the activated state. For example, if a patient who is not taking a proper sleep at night, for example, you have come all the way from different places, and some people will have come from nearby places. If we are checking, maybe we will be doing motor, like MT when we are doing motor threshold in the evening, we'll know it will be varying. And once you are taking rest, again, if you are doing in the morning with adequate rest, it will vary. So the how it is getting depolarized also depends upon the state of the neuron, how it is there. And it is basically based on the concept of the intensity and duration, like chronoxy and ribose. So what are the other mechanisms? One is neurotransmitters. It modulates the activity of GABA and glutamate, and we all know that the neurotransmitter, when we apply directly to either equivalent of ECT or a depression, we know that these activities are impaired in depression, and rTMS modulates and increases the GABA activity by which it is producing an effect. And the most important concept is synaptic plasticity. So this is the most accepted and crucial one, where people have seen in animal studies that rTMS produces a long-lasting increase in the amplitude of excitatory postsynaptic potential. So if it is like that, then it will cause modulate the cortical activity beyond the point of stimulation. So it is actually doing something at the time of stimulation also, and through LTP, it is having an after effect beyond the point of stimulation. And but the temporal order in which the synapse is getting stimulated, whether we are stimulating the presynaptic or postsynaptic, how it is getting done, will determine whether it is we are having an excitatory effect or an inhibitory effect. So on stimulating first the presynaptic neuron and then the postsynaptic neuron within an interval of a few tens of milliseconds, people have found that there is an increase in the synaptic strength, which is the long-term potentiation. And like high frequency, which is more than 5 hertz, lead to excitatory effect through this mechanism. Basically, to like I have simplified it for understanding, but this is what exactly the when we can simplify this is the thing. And if the stimulation is in reverse order, by postsynaptic neuron before the presynaptic neuron, then it causes decrease in synaptic strength, which is long-term depression. And low frequency stimulation acts having an inhibitory effect by this mechanism or disrupting how the basic neuronal function is happening. So this is the most important mechanism of rTMS. And other mechanism is this is a DTA image of the brain, which is used to understand the subcortical connections, right? So people have found that rTMS have changes like the default mode network, salience network, and central executive network. All these networks are there in the like demonstrated excessively in patients with depression, and studies have found that pre-treatment hyperconnectivity within the default mode network decreases significantly after rTMS, and also the hypoconnectivity within the central executive network at the baseline improved after rTMS. And also the connections between these networks and different parts of the brain is also getting rebalanced. So basically, ECT's mechanism is resetting the brain's function. Like that, rTMS also, there is some kind of resetting happening in the dysfunctional connectivity pattern, leading to the clinical effect of rTMS. And also, rTMS causes an epigenetic change. And like studies have found that it through the inhibiting the Golgi apparatus stress and multiple other activity, it causes an epigenetic change and modulates the oxidative stress in the brain, and through which also it produces a it has a neuroproductive effect. So basically, to combine, rTMS has multiple effects like thing this is so it has through synaptic plasticity, through the neuronal changes, and also certain other activities are there which is not demonstrated, like through the direct magnetic effect on the brain. So all this produces, all these are mechanisms proposed for the effect we are having in rTMS. So what are the different things we'll be seeing? So the subsequent speakers will be saying about the FDA approved protocols and other applications. So before that, we should know what is the machine and how it works. I think it's audible, right? It's not breaking. Okay, fine. So, so this is basically an rTMS machine. I have put certain things, like I have to have a disclaimer. I'm not saying anything, but there are only few players. I think there are only 9 to 10 players in vendors who are supplying. The first one is like the Brainsway, which is DTMS, which is used multiply now, and they have most of the FDA approved protocols. Second one is MacVenture. This is Neurosoft. Apart from that, MaxStim is there, and rTMS is there. So multiple other Medicaid is also there in India. So all these rTMS machines are there. So basically, what this machine has, like when we know every machine has one stimulator. So the stimulator is the one which is the which has multiple things, like it has a charging system where it has to generate a magnetic field, and then there is an energy storage capacitor because it has to give the current intermittently. It has to give, then again recharge, and again they have to give the current. And then there is an energy recovering unit, and there is a thyristor where electrical device capable of switching large currents over a short period of time. So it bridges between the coil and the capacitor. And there is a pulse shape circuitry. So all these things are the basic parts of the stimulator of rTMS. So then we have different coils. So why coil is important? So how the coils are being placed will generate the magnetic field and will have a secondary current, induced current. So coil plays a crucial role, and these are the few coils commonly used. One is the circular coil, which is the oldest, which delivers a single pulse, and it is not used for our means in psychiatric purposes, but for research purpose it is essential. This is one of the things previously used. What we commonly use is the figure of eight coil. So this is the most commonly used coil for clinical and academic purpose nowadays. And most of the FDA protocols are based on the cigarette wick coil. And it has two single circular coil, and in the midpoint is the induced current. This maximum will be at the, and then we have to this can stimulate the superficial cortex of the brain, but what to do for the deeper thing that we were discussing, that RTMS had difficulty in doing so. So people started giving angulation to the coil, so there can be 150-degree angulation or 120-degree angulation. So this is one coil which is a double cone coil, where specifically designed to reach the deeper cortical structure used in OCD and other disorders, and the coil is bent at 120 angle to suit the shape of the head. And there are also 150-degree angulation is also available. And people thought, why to make different coils? Like we have to, even with these things, we can't penetrate the deeper structures. So Brains, they devised this coils, which are H1, H7, and H4 coils. And they have more complex design, but basically what they want to do is they want to penetrate the deeper structures, and they can penetrate up to 6 centimeters below the cortical surface. So this is basically about the different coils. So we have seen there is a stimulator, and there are different coils which are required for rTMS, and we have other accessories also. This is not done like when we go back and we'll start buying machine, we'll feel okay, we'll get a stimulator, we'll get a coil. But the problem is it creates a magnetic field which is as high as 2.5 Tesla, which is equivalent to an MRI machine. And it has a lot of heating issues. And the precision and localization is also important. So for that, certain accessories are required, like a coolant system. The coolant systems are basically, there are different cooling systems like air cooling system or liquid cooling system, where a fan dissipates the heat from the coil, like we have in the laptop. A fan is running. Similarly, it is not as simple as that, but this is how it works. Or it's a liquid coil, liquid cooling coil, where around the coil there is another parallel system running, and it has circulates the coolant, and it is for the heavy duty purposes like rTMS. And there is also a static cooling mechanism, but it is only with few machines. And then it has to come with a temperature sensor, where it has to automatically cut off after a certain point of time. Otherwise, it will lead to overheating, and that can actually affect the clinical effect. And then we have to, like, there are some accessories are important. Patient should have a comfortable chair, and also there has to be an articulating arm which we can place the coil. So if we have placed the coil, we can't keep the coil in hand for long duration of time, right? So we have to locate it, fix it, and patient's head also we should be in a similar position. So these things are important. And there are motorized robotic arms also, where if the patient, even if they are shaking the head, the arm will also adjust accordingly, and will be able to deliver a precision, effective precision. And then apart from that, it needs a lot of power. So there has to be an isolation transformer, so which reduces the current leakage and is able to distribute the power to all the things whatever is required. So these are the basic parts of rTMS, right? So we have seen what is the mechanism, what are different coils and other stuff, and what are the areas to stimulate. Areas to stimulate, most commonly what we all know is dorsolateral prefrontal cortex, and apart from that, there is a subliminal motor area and temporoparietal junction. So the dorsolateral prefrontal cortex is stimulated in depression, negative symptoms of schizophrenia. People will be talking about it later. And supplementary motor area in OCD, and temporoparietal junctions in schizophrenia, auditory hallucinations. So all these protocols are commonly used. And how to localize the target. So we know that, okay, this area is there, we can stimulate it. So we can't go about it. There has to be some principle. The most commonly used anatomical landmarks are 1020 EEG system. So based on the 1020 EEG system, we can localize, but it is less accurate. And currently, people are coming with neuronavigation, where MRI guided things can be uploaded, and it will give a model, and through which we can stimulate, we can use structural and functional imaging further, including TT images, MRI, and fMRI images. For anatomical landmarks, we have to know about how it is done. Like the motor cortex is seen, and after that the prefrontal cortex is stimulated. So motor cortex is functionally localized on the scalp position, where TMX evokes a motor movement, which is a measurable motor evoked potential in the contralateral hand. And the prefrontal cortex is initial studies have shown that left DLPFC stimulation site is around 5 centimeter anterior to the primary motor cortex. But then further studies which were coming shown that it is of like the accuracy is not that much, and now they are suggesting it is around 5.5 or 6 centimeter, which is anterior to the motor cortex is the left DLPFC. And there is also another approach, which is beam F3 approach, where basically there we can measure the distance from nasion to union, tragus to tragus, and head circumference. If we upload all the measurements, it will give certain values, an X and Y value, and we can measure it from the nasion and also from the tragus, and then it direct located the DLPFC, right? So these are two approaches, and people have seen that both the approaches are quite okay. And this is how the software appears, and this is how the values will be given in it. And this RCT shows that both F3 approach and 5.5 approach is relatively equipoised, but neural navigation is definitely better. So these are the two approaches most commonly done nowadays. So this is for the motor area and DLPFC. Apart from that, there are other areas we have to know. For the 10 AG system is better or neural navigation is better. So one is orbitofrontal cortex or dorsolateral prefrontal cortex that we have seen. The supplementary motor area, which is between the when we are calculating from the vertex, it is just anterior to the CZ point, and there is temporoparietal junction. So this are the basically about the localizations. We can go back, it is already given, it is available online, you can read about it. So basically this is what we have to understand. And then, so after we have got localized the coil, we know where to stimulate. We know about the what rTMS is and how it is working. But this is not sufficient. We have to know about the protocols. So protocols, speakers will be saying about different FDA approved protocols, but there are basic principles in protocols. Like one is which is the pulse form or wave we are going to use, and what is the stimulus strength, what is the resting motor threshold of the patient, how to calculate it, and based on this, how we are going to calculate the stimulus strength, and then what is the frequency and duration we are going to give, and how long we are going to give, and what is the gap we are going to give, that is the intertraining interval, and the course. So all this will basically determine how the rTMS is going to function. So there is there is single pit TMS, which is used to explore the brain functioning and induce the brain activity, and then it has both monophasic and biphasic. Monophasic is mostly used for research purposes. What we are having is biphasic, where current reverses direction, commonly used in therapeutic principle, and there are patterned protocols where these pulses are combined in different bursts. Like intermittent theta burst and continuous theta burst. Intermittent theta burst have respiratory effect, and continuous have inhibitory effect. The similar strength. Non-invasive TMS of motor causes these to switch in the target muscle, and the target muscle is based on this, we can find out the most evoked potential. By definition, it is the minimum intensity that produces visible muscle twitch in the contralateral abductor pollicis brevis. Usually, when we are doing MT, there has to be, we give 10 trials, and the study shows that if more than 5 out of 10 trials patient is having an MT, then we can fix at that point. It can be varying. It can be 25%, 30%, 40%, whatever the machine says, we can stimulate accordingly. And we have to, ideally, we have to assess every day when the patient when we are going to give the session, we have to stimulate it, because as we discussed, it can vary with our physiological state and what we are doing, what are the drugs we are taking. So it has to be reassessed ideally daily, but if not possible, at least weekly, or whenever there is a change in medication or something, we have to reassess. So this is when we are giving a stimulus, that activates the neurons which are oriented horizontally in the plane, parallel to both the cornea and brain surface, and the corticospinal tract is getting stimulated, and leads to a peak-to-peak amplitude of motor evoked potential, and the motor threshold is identified. And this is defined by the at least 50 millivolt in about 50% of 5 to 10 consecutive trials. So basically, this is how we're going to calculate MT. We'll be seeing in the subsequent things how we will be able to do it. So we have now identified the protocols, and we are now done. Like, we have to just whatever the things which is in front of before giving the sessions is done. Then we have to determine how it works. So the further speakers will be saying about all these things like what is the protocols approved and how to give it. So basically, when we compare, this is the like okay. Basically, there is when the protocol which is initially approved for depression has 10 hertz, which is and the train duration is for 4 seconds, and intertrain interval has to be given, which is around 26 seconds. And then overall, then in a session, there will be 3,000 pulses. And the stimulus we are giving at a strength of 120% of motor threshold. And the sessions is around one session per day was initially approved, and 5 sessions per week, and over the course it is around 30 sessions. Total cumulatively, we have to know how much pulse we are going to give in the overall course also, and what is the target area and how we are going to measure it. So all this we should know it, and we should apply it. Based on this, we can stimulate, right? And these are different FDA approved protocols. But the coil which is used for the initial one is a figure of 8 coil, and there are other protocols for OCD and smoking cessation. For OCD, as we have seen, they will be using like double cone coil, which is a angulated coil, right? And then we have the new advances, which is one is theta burst. It's not relatively new; it is more than 10 years, but the pattern of theta burst is actually based on the brain rhythm, how the hippocampus is functioning. So, like the 5 hertz, but 50 hertz is given in different combination. And the intensity is we usually do theta burst in a lesser intensity. In the older protocols, we're using 120% of motor threshold. Current one are using around 80% motor threshold. And there are intermittent theta burst. Protocol is applied for 2 seconds. And then there is a gap of 10 seconds intertraining interval, and then 8 seconds. And overall, with the 10 seconds, it is given. So it leads to motor excitability. Continuous protocol without any pass, you are repeated for 40 seconds. So it leads to an inhibitory effect. So this is the protocol initially approved for theta burst, which is a 5 hertz at 50 hertz in intermittent theta burst. So train duration is for 2 seconds, intertrain interval is for 10 seconds, and pulse duration in a session, pulse dose in a session will be around 600 pulses. Number of session is 1 for 5 days we have to give, and total course we have to give for 30. So cumulatively for a course, we will be giving around 18,000 pulses, and target area is DLPFC. For every session it lasts for 3.5 minutes. So basically, with the older protocols, every session lasting for around 26 minutes or 30 minutes, and newer protocols lasting for only 3 minutes. And initial protocols they were giving for one session per day, and newer protocols, accelerated protocols, are giving more than 10 sessions. So theta burst use the same figure of 8 coil, but the thing is, when the coolant facilities and other things are has to be there for theta burst, because it will easily get heated because we are giving a higher frequency. And so this is basically about my presentation, and the further presentations they will be talking about how to select a patient. So basically we have to screen for contraindications like metallic implant, whatever similar like for MRI is actually a contraindication for rTMS2, and there are relative contraindication because we are giving a high frequency. There is risk of seizure. When the patient is having a high risk of seizure, then that is also relative contraindication. There are uncertain contraindications, multiple people have said like if there is an implanted brain electrode, pregnancy, or recent or severe heart disease, all these things are uncertain contraindications. And there are checklists like transcranial magnetic stimulation adult safety screen, which has 14 questionnaire which assess have you ever had an adverse reaction to rTMS, seizure, have you ever had an EEG, have you had a stroke, head injury. So all these things are assessed. Similarly, there is another question, which is screening questionnaire for TMS. So basically, this is about the like start with TMS and how to proceed further as an overview, right? So thank you, and this is like all these are new protocols where within a day we can give around 10 sessions. So with once we are knowing about the FDA approved protocols, this will come up, and this is where we have reached. Now TMS, they are something is approved even for mobile TMS. We can give on the go, it can be given. And so we need not need a large space Or I think this is how the future is going ahead, and let's see where it takes. Thank you.
Thank you, Dr. Rahul. Now the session is open for discussion. Any doubts or clarifications, you can ask the speaker. You can also check any questions are there in the chat box. Also, people who are online, you can put on your queries in the chat box. I think there is one question in the chat. Thanks in RTMS.
Implants in rTMS, contraindication.
This questions. Can ask the person to clarify the question.
They can unmute and ask, like, it's possible, like, or clarify, they can put in the chat.
So is there any possibility of giving RTMS in patients who are having some implants? Maybe that is a question.
Yeah, like that is what the subsequent speakers will be talking about, like how to select a patient. We can't give rTMS to every patient. There are certain things which facilitate that the patient needs an rTMS. There are certain things which decides whether the patient should not be given. And the contraindication basically is relative to MRI. Like it is we are giving a magnetic field, and the magnetic field will have a definite with advances maybe the test level also go up. So it should not have an adverse effect. So if the patient has recently received an MRI and that's the rule, then in the last few months if they have done for MRI, then rTMS can be given. So basically this is the understanding as of now. Maybe with further studies we'll get better.
There is one more.
Excellent presentation. Thank you. Is there any age limit as per guidelines? Age.
Yeah, thank you. Like the thing is, age limit as of now is mostly in adults, but in children also there are few studies coming up which have seen effect of rTMS in children, and so the indications they are using it for OCD and also for depression in children studies are there, but evidence-wise, it is mostly in adults as of now. Most of the strong evidences are neuromodulation because whatever the neuromodulation is techniques are, it is having an effect on synaptic plasticity and having a long lasting effect. So in children, when the brain is developing, we will never know how it is going to cause a long lasting effect. So doing a study and have ethical considerations also. But studies are there. When patients with severe illnesses, people have tried rTMS and definitely it is working.
Okay.
Is there any question in the chat?
Yes, I think part of the questions which are asked to be addressed in subsequent sessions. So clinical evidence, age, contraindications.
I think the current first session is on electrophysiological basis and also the basic protocols and the basics of rTMS. I think the clinical application, the various protocols will be discussed in the further sessions. So if anything related to this topic, any queries is there, you can type in. Any more questions from the audience here? So it was a very wonderful presentation. I mean, it's like uh, I usually say the basic things are very difficult for us to present. The advanced thing, there are lots of evidences, and we can just talk about those things. But to make the audience understand the basics is the most difficult task, and I think you have done it very well. So right from the various types of machines available, various protocols, the parts of the machines, and the basic electrophysiology behind it. So all those things were very clearly explained to the audience. So that's another reason why maybe people are not able to ask questions because they are able to understand most of the things that you asked. So with this, I think we can close this session. Thank you, Dr. Rahul Ganesh, for this wonderful presentation once again. Thank you to the organizing team for the opportunity. Thank you, everyone.
Thank you, Dr. Rahul Ganesh, for setting the stage and standard for the upcoming speakers with that engaging and informative talk. Thank you, Dr. Sridhar, for chairing the session effectively. I now request Dr. Sabari Sridhar to kindly felicitate Dr. Rahul Ganesh. I now request Dr. Priya Shivashankar to felicitate Dr. Sabari Sridhar. Thank you. Thank you, sir. I now invite Dr. Rajkumar to chair the next session on the topic FDA approved rTMS protocol, scientific evidence and clinical application in psychiatry. Dr. R. Rajkumar, ex-professor and ex-HOD of Sri Balaji Medical College and Hospital, whose areas of interest lies in de-addiction psychiatry, neurocognitive assessments in diabetes, community psychiatry, and training in drug dependence. Adding multiple publications in the field of psychiatry and various awards, it is a honor to have you as a chairperson for this session, sir.
So sorry for that technical glitch. I'll start again. So before moving ahead, I would like to talk about regulatory bodies and more about the approval processes that happens. So there are various regulatory bodies all around the world, and the most important ones that we know are the US FDA, that is the Food, Drugs and Cosmetics Act, and the European counterpart, that is the CE. Now, both has its own advantages and disadvantages. FDA on one hand being more cumbersome, difficult to obtain pre-market approval, and the CE being a relatively easier process, but it requires a more robust marketing surveillance. The onus is more on FDA when approval processes are concerned, and the onus is more on the manufacturer for their internal regulation process so that the device continues to stay in the market. The Japanese counterpart, that is the PMDA, is more like CE and is relatively easy, and but the onus lies both with the manufacturer and as well as the regulator. There are various other regulatory bodies as well, but for now we'll talk more about the US FDA. This is how a US FDA approval is taken. These are the bodies which regulate the neurological and psychiatric neuromodulation devices. Under the FDA, there is something known as CDRH, and under the CDRH, there is something known as OST5. And within the OST5, there is neuromodulation psychiatry devices team, which is responsible for supervision and approval process of any neuromodulation device concerned with psychiatry. Now, FDA classifies devices as class 1, 2, or 3, with regulatory control increasing from class 1 to 3. It means that the class 1 devices are low risk and the class 3 devices have the highest risk. There is no neuromodulation devices which are used in psychiatry at present under the class 1 device. Most of them come under class 2, including rTMS. In India, CDSCO is responsible for regulatory processes, but currently there is no neuromodulation device, or if I am not wrong, there is only one neuromodulation device, that is TDCS device, which has recently taken a CDSCO approval. Because most of the devices that are used in India are imported, and it lies on the onus of the vendor or the local sponsor inside a country, or specifically inside India, to get all the regulatory processes done. So from manufacturing perspective, only one TDCS device has recently approved CDSCO clearance. Now, what are the various FDA cleared therapeutic indications? When we talk about FDA clearance, so it's not a particular indication, it's not a particular device, it's not a particular coil, or it's not a particular protocol that are separately cleared. Everything is done in combination. So if there is an FDA clearance, it would be in a combination of machine, coil, protocol, and indication. It doesn't go separately. So it doesn't mean that if a particular protocol has been approved for a particular machine, you can use it on a different machine, and you can use an US FDA excuse to use that. Although there is nothing of people are using in that way, and there is no regulatory process to say that you cannot use it in this particular way using different machine for different protocols. But US FDA has clearly stated that this machine, this coil, this particular protocol, and this indication. So these are various indications: major depressive disorder with comorbid anxiety, OCD, smoking cessation. Recently, it has also been approved by the US FDA for people, for adolescents more than 15 years of age. So this timeline shows how the FDA clearance has happened. It's a bit blurred, but I hope it's a little bit visible. So for now, MDD, migraine with aura, is also something which has been approved, but the traditional TMS devices that we use does not have the protocol that migraine with aura has been approved for. And it's a completely separate device, that is the Sprint TMS. These are various TMS trademarks which have taken US FDA or CE mark and of them the majority, most of them which are used in India are MaxStim, the MagVenture device, the BrainsWay device, and today we'll also be seeing the device from Remit, that is the rTMS, and so these are various devices which are used predominantly in India. There are other devices as well which have been approved. So what are the various challenges that we see in real practice? So the first question that arises is, does rTMS really work? Okay, so a lot of them have there in their mind, and you can even ask, does SSRI work? You know, non-psychiatrists do ask that, does SSRI work? Antipsychotics do work, but do SSRIs work? A lot of questions are there. We as psychiatrists believe that SSRIs work, but laymen, and how can a molecule, change your brain or thought process? How can they do that? Similarly, these questions have been answered over ages, and various rTMS studies will continue to answer these questions as well. No doubt there is a huge placebo response, but that is true for each and every medicine in the medical specialty. So what type of patients are suitable if it does work? What are the indications for rTMS? Now there is a huge challenge of providing daily sessions. People won't agree to come in daily, and the cost is too much, right? So is there a scope of optimization of the treatment protocol so that we make it a more rapid kind of a treatment modality? How long does the improvement last? This is a very important question. Does it last long enough to invest so much? And how to plan maintenance treatment? So what are the considerations when we want to choose rTMS in the treatment regimen? So before moving ahead to the established FDA approved protocols, we're talking a bit more about the patient selection. So treatment resistance has been, treatment resistance is something which has been focused too much upon. Okay? But there is no definition per se, which is a very standard definition for treatment resistance. There are a lot of variety or variations in treatment resistance that exist. So you cannot tell whether you want to give rTMS in one antidepressant failure, you want to give antidepressants out of 4. So different people have different ways of practicing it. So there is no one consensus. So a lot of things have been done, but the only thing is that about varying degrees of resistance, efficacy of rTMS has not been established yet. Where do we position rTMS in sequential treatment algorithm? Now, generally, ECT comes in the last, right, as a last treatment resort. Generally, ECT comes as a last treatment resort, okay? But does it hold true for rTMS as well? There are uncertainties regarding exact positioning, but superior tolerability ideally should favor. There are various insurance policies and issues related to insurance which does not favor its superior positioning because it's a costly treatment and insurance companies won't be giving you claims for earlier treatment. Medicines are relatively cheaper, okay, but since it has a superior tolerability, if affordable, should come earlier in the treatment algorithm. Also, compared to medication switch, there is superior efficacy and tolerability. And the cost-effective analysis, if done, it's almost equal or even better. Patients with less than or equal to 1 failed medication have more superior outcomes compared to higher level of medication resistance. So these are studies already done and research has shown these findings. Now we also think that one size fits all is an approach that we can use in most of the patients, but it's not true. You need to individualize. As a practitioner, people come to know that you need to individualize treatments for various kind of disorders within disorders also, because if you go by ICD-10 or ICD-11, they have just given symptoms, but we all know depression or any kind of psychiatric illness is not just one illness. There are various inter-individual symptom variability which are present, and we need to be very symptom specific when we are treating any patient. Similarly for rTMS, one has to be symptom specific, one has to have individual approach when you are approaching a patient and you are discussing an rTMS treatment paradigm with them. Sorry? in the yeah. So rTMS can be used for investigational purposes. Yeah. rTMS can be used for investigational purposes and therapeutic purposes. Okay. Now, when there is a very high sensitivity to psychotropics, not everyone can tolerate medicines. Right? Higher sensitivity to medication side effects, mostly among extremes of age. Any presence of medical comorbidities would warrant you to go with a very safe treatment rather than going ahead with a something like ECT because it involves anesthesia. Hepatic or renal dysfunction, peripartum. So recent evidence has come up which shows that it's relatively safe in pregnancy, and if there is a risk to benefit ratio is less. So you can definitely go ahead in patients with peripartum, specifically in first trimester when you cannot give a lot of medicines. Family history of sensitivity to psychotropics. Neurological conditions like Parkinson's disease. So after a certain time, there is a sensitivity to levodopa that happens, and there's too much of dyskinesias. So rTMS can also be used to treat the motor symptoms of Parkinson's in those particular problems. And one very important problem that comes up in routine clinical practice is OCD with comorbid bipolar disorder. You cannot prescribe too much of SSRIs or antidepressants in patients who have OCD. There's a high risk of treatment emergent switch. That is true even with rTMS. But with given low frequency rTMS, things can be different. So rTMS can be an option in this particular population. So when we talk about selection, preference of patient is also really important. Because rTMS is non-invasive, there is a better patient, acceptability. And there are minor and transient adverse effects. It's a non-pharmacological option. People don't want to take medicines, so people do want to go ahead with those who can afford. There is a quick recovery because there is very less wait time, and a person can come in, take the session, and just walk away. There is nothing else involved, and it's an outpatient procedure. Now, the adverse effects are relatively very safe compared to what ECT has, and there is the most dreaded one is seizures, right? But the seizure is so rare. Only 0.1% patients who are undergoing TMS will have a seizure in their treatment sessions. Now, this is the highest I'm telling. Some research has also documented, rates of maybe less than 0.03%. So the rarity of seizures is it's very rare, and we need to, if we effectively rule out any possibility of any high risk population or any person with a high risk of seizures, the chance of a person having seizure with TMS goes down even less. With better choice of protocol, giving the stimulation intensity at the required dose and not at a suprathreshold level. So all these parameters can decrease the chance of seizure to a very bare minimum. There are other side effects as well, but they can be fairly easily managed. Now, it is only used for augmentation strategy, not as a standalone treatment. Although there are arguments for it as well to give it as a standalone treatment in patients specifically who are not wanting to go on medicines at all. Okay, and they do not want any kind of therapy, they want a fast result. And even after continuous psychoejection, they are not willing to go ahead with any other kind of treatment. So for them, you can use as a desperate measure, but it is always better to use it as an augmenting agent because combination with medication has a superior result when given as compared to when given as a standalone treatment. If there is a need of rapid response, okay. So for rapid response, there is an argument that you can use accelerated protocol, but more research needs to be done with higher sample sizes in order to confirm the efficacy of higher accelerated protocols being superior to daily one sessions. Okay, accelerated protocols are more than one session in a day. So when there is relative lack of other biological options, so then comes neurotechnologies. Okay, so in neurodegenerative disorders, in neurodevelopmental disorders, And negative symptoms, there are very few pharmacological options that can be used for negative symptoms of schizophrenia and cognitive symptoms of schizophrenia. For them, it becomes comes in as a desperate measure, and people have seen improvements in these particular symptoms with particular coil placement and protocols. A very thorough workup needs to be done. We need to rule out pseudo resistance so that the person is able to have the most benefits. Personality disorders, very big no. You cannot use it if the symptoms are arising solely out of personality disorders. Okay, contraindications needs to be ruled out. Any medications which can lower down the seizure threshold needs to be kept at a check. For example, clozapine. Active substance abuse, any kind of substance which is influencing predominantly GABA needs to be taken care because it can, increase the seizure threshold and the effectiveness of rTMS. So the excitability is altered due to these GABA agonists. And there needs to be clear and transparent consent process which needs to be in place. So you need to screen for contraindications. Any metal within 30 centimeters of the stimulation site, within 30 centimeters, is is considered unsafe. Now there are recent guidelines which have come up that lesser distance can also be considered as safe, but this is what has been recommended till now, 30 centimeters. If there is a very high risk of seizures, rTMS has been given as a treatment in refractory epilepsy as well. It's not that it's not given, but low frequency protocols are given in refractory epilepsy, not the high frequency one. Although the difference between the statistics or the research shows that there is not much of a difference when seizure rates are concerned in low and high, but to be on a safe side, we give low frequency rTMS in people who have epilepsy, but there needs to be a high risk consent taken before you go ahead. If you feel that the risk versus benefit is low in a patient, the benefits are more than the risks involved, only then go ahead with people who have epilepsy. But if you want to play safe, avoid any patient with known case of seizures or epilepsy in the past. If there are some uncertain risks as well. This is a checklist that can be used to rule out contraindications. These are some of the patient-related variables. Now it has been reserved for only severe neuropsychiatric conditions. So it's a huge investment, right? So not everyone will go ahead for it. So what in routine clinical practice we do? Okay, this patient is not improving. He has a very severe indication. Now that is in itself an injustice to treatment. Okay, because it's a non-invasive treatment. How much are you going to expect from it, right? So reserving it only for severe indications will give you relatively poor results when compared to giving it at much moderate or milder levels of symptoms. You need to assess the socioeconomic status, logistics, suggestibility and positive outcome expectancy from the patients can alter. If there is too less suggestibility, the patient has a very negative attitude towards the treatment, as well as if there is a very high positive outcome expectancy, then the placebo rates will increase. So that needs to be taken care of. Pharmacophobia among patients. You need to set the expectations beforehand, before starting TMS. The cost of TMS is an investment and not a waste. Okay. Lesser duration of protocol doesn't necessarily equate to lower effectiveness, specifically when theta bus protocols are concerned. They are of very less duration. So patients may say, okay, I'm being given a very less duration of protocol, so that's why it's not affecting me. So that needs to be clearly set beforehand. Target symptoms which are expected and not expected to improve are because people may have comorbidities. They will expect that if I am investing so much, I should be remitted of all the symptoms. Okay? So that there should be only few symptoms will improve with rTMS, and that should be told to the patient beforehand. Extension of treatment may be required. Early termination may also be required. Okay. So some people may have delayed response to treatments. So for them, extension of treatment may be required. Change of target start location, because most of it is being done on an assumption basis. Okay. So not all depressive patients will have primary DLPFC as the target, as the culprit. Okay. So people may have other sites as well. We do not have the fMRI data of that patient. So may need a change of target site in future. Seizure is only a remote risk, but that needs to be explained to the patient. and it should be very freely communicated. Do's and don'ts when undergoing RTMS. There are various things which we'll be discussing on the workshop that you should do and not do. Conflicts of interest, public promotion of off-label use. That needs to be very clearly documented. If you are giving for it for an off-label use, it's an ethically gray area. You can go ahead if they are not responding to other treatments, but that needs to be said that this is not approved and we are giving you as an off-label treatment. Transparency about efficacy when using TMS for off-label condition. Income associated with offering RTMS can have a significant conflict of interest among providers. And so there is a huge cost involved in setting up an RTMS clinic. So financial burden may happen that it is passed on to the patients. So these are some checks that we need to keep in mind when we are taking in RTMS as a treatment. So there is no intervention that is planned when placebo is concerned, including RTMS. So care is delivered in a tertiary care or a very very good setup clinic. Okay, so the person automatically feels that they are going to improve. So that in itself creates a positive outcome expectancy. It's a novel technology, so expectation increases, and there is a constant screening, treatment delivery, calibration. Patient is coming out. They are involved in a lot of behavioral activation. So these are some of the measures that can lead to placebo response. But a recent meta-analysis shows that there is not much of a difference when placebo responses are concerned among various psychiatric treatments when response and remission rates associated with placebo were concerned, although the heterogeneity was large among this particular meta-analysis.
கூட யார் இருக்கா?
So it's not necessary that
வேணுமா?
if you like a treatment,
விழுறத யார் பார்த்தா?
will be effective.
எப்படி
And vice
விழுந்தாங்க
versa.
அவங்க?
If you don't like a treatment, it won't be effective. So if it is indicated, if it is known to improve something, and if it is indicated in a particular patient, you should go ahead with it rather than with your own personal biases. So these are various permutations and combinations that can be used in
முன்ன
order.
விழுந்துட்டாங்களா இல்ல இப்படி சரிக்கு பின்ன
We now move to TMS protocols. So these are some of the various typical RTMS parameters which
எவ்வளவு
have
படி
been
இருந்தது?
discussed with the in the session conducted by Dr. Raghu.
அவ்வளவு ஹைட் இருந்தது.
So there are two kinds of TMS currently, single pulse TMS and burst TMS. Okay, burst TMS is also known as pattern TMS. So in single pulse, high frequency or low frequency single pulses are given at regular intervals.
நினைவலா இருந்தது அதுக்கப்புறம்.
Burst set of 3 pulses are given at regular intervals, and these set of 3 pulses are given at 50 hertz frequency. And in pattern TMS, what happens is that these set of 3 pulses are given at theta rhythm. Theta rhythm is somewhere between 3 to 8 hertz. Okay, so median is used, that is 5 hertz, and these set of 3 pulses are given at 5 hertz. Okay, so 3 pulses are given at 50 hertz, so that is a single set of pulses, and these set of 3 pulses are given at 5 hertz intervals. So why theta burst? Because it causes a lasting entrainment of frequency specific oscillations. We don't go deep into physiology of this because it's out of the scope, but this is what it does. So ITBS will cause facilitation and CTBS will cause inhibition, and thus long-term potentiation and long-term depression. So this is conventional TMS and this is pattern TMS. Okay, so there is something known as quadripulse stimulation recently coming up. If there is a long interval between the quadripulses, it will lead to inhibition, and if there is a short interval, it will lead to facilitation. So these are some of the FDA cleared protocols. Okay, so FDA has cleared only 10 hertz rTMS. 10 hertz various coils are being shown over here. Left DLPFC, and for H1 coil specifically, it stimulates differentially the bilateral DLPFC. So the left is stimulated more than the right. When intermittent theta burst is concerned, there are two protocols that have been approved: 600 pulses per day and 18,000 pulses per day. So 18,000 pulses per day is an accelerated version of the ITBS protocol, which is also known as popularly as the Stanford Accelerated Intelligent Neuromodulation Therapy, that is the SAINT protocol. Now with comorbid anxiety, also it has been approved now, and for OCD specifically, ACC MPFC area, which is the it is relatively anterior to the SMA region, and For that also it has been approved, the H7 coil and the DB80 coil specifically. And for smoking cessation, it targets the bilateral inferior prefrontal cortex and bilateral insula. Now, when we talk about evidence in depression, we all know that left high frequency TMS is has definite efficacy. Left DLPC high frequency. There's no doubt in it. Right may have some probable efficacy. People argument that it is more effective in anxiety or comorbid anxiety. Bilateral TMS may not be more than high frequency, but there are arguments against it. Some people say that bilateral may be more effective. Now, when we talk about bilateral, it's a sequential treatment. Okay, either you give left DLPFC first, then right, or right after that you give the left DLPFC. So there is arguments for and against which is superior, right to left or left to right. Left ITBS is non-inferior. So there was a trial, the 3D trial, which said that even with shorter duration of session, you can achieve similar results. So ITBS is also equally effective, if not more, as compared to high frequency TMS. For right CTBS, as an inhibitory protocol, we do not know much. Bilateral TBS, nothing has been done. This was the 3D trial, which compared the 10 Hertz protocol to the ITBS, and they found that it was non-inferior. So this was a network meta-analysis which has suggested that ACT is the go-to treatment when psychotic depression is concerned. Okay, there is no other alternative. TMS may not do much when psychotic depression and very severe depression is concerned, but TMS does play a role in relieving depressive symptoms, specifically the high frequency and low frequency, and there is some evidence to intermittent theta burst. MST is showing good results, but and also has better tolerability profile compared to ECT. So do not change any antidepressant or antipsychotic while the person is on TMS. Okay, it acts as an augmenting agent for TMS. You need to reduce benzodiazepine. Do not play with the sleep cycle of the patient. The minimum amount of benzodiazepines with which this person can sleep or can have reduced anxiety needs to be given, but it has to be at a minimum so that the excitability does not compromise. But for bipolar depression, there's questionable evidence that it has the same efficacy. Some say that it has relatively less efficacy. There are some reports which suggest that it can induce suicide. TMS can induce suicidal tendencies, but it's only because if the TMS is not working and the depression in itself is worsening. So there's no underlying physiological way or any neurobiological markers through which we can say that okay, TMS is directly inducing suicidal tendencies, but definitely has some anti-suicidal effects. So these are some of the response predictors: younger age, shorter episode duration, current episode, and recurrent depression. So if the symptom burden is less, TMS may be more effective. If the symptom burden is more, TMS may be a little less effective. With chronicity, the effective efficacy of TMS may also decrease. These are some of the neurobiological methods through which you can see whether TMS would work or not. So high frequency to the left DLPFC is the go-to if you want to start TMS for people with depression. So the number of sessions would be somewhere 20 to 30, maybe more than 30 would give you a better result. And this is the protocol that was used for FDA approval study. Right. So how to optimize treatment protocol? The number of sessions you need to decide, frequency of sessions you need to decide, in the stimulation parameters. Okay. So standard protocol is once daily session for 20 to 30 sessions. Can we increase the frequency of stimulation? Yes, we can by means of accelerated protocols. And can we decrease it? Some say that even 3 sessions in a week may work, but needs more evidence for that. Can the frequency be decreased for patients who are unable to come every day? Yes. So spacing between sessions, accelerated protocols. So cumulative TMS exposure or TMS pulses delivered during a treatment course is driven by 3 main factors: the number of treatment days, the number of treatment sessions per day, and the number of pulses per session. Okay. So for how long the treatment would continue, the number of days, that on one day how many sessions the person is receiving, and in a single session how many pulses they are receiving. The standard we all know, but more than one TMS daily session can be given, and the inter-session interval should be at a minimum of 30 to 60 minutes and not less than that to have a better neuroplastic and long-term effects. Yeah, so the goal of achieving similar or superior levels of efficacy in a lesser time. So accelerated theta bursts because it reduces the time and it's more feasible. You cannot give, extended sessions for maybe 5 sessions. For example, a 20-30 minute sessions, you cannot give 5 sessions at a day. The TMS machine would be occupied by one patient only. So that is why accelerated protocols use mostly theta burst protocols because they are of lesser duration. So this is the same protocol. Okay. Now the important part over here is that they use resting state fMRI. Without resting state fMRI, you cannot call it as chain protocol. You're not using resting state fMRI. Okay. So what it does is that it detects the DLPFC location, which is the most anti-correlated with subgenual ACC or subgenual anterior cingulate cortex. Okay. So that can be done only through fMRI and through fMRI neuro-navigated guided target localization. Okay. 10 daily sessions are given over 5 consecutive days at 90%. So always for ITBS, the resting motor threshold has the stimulation intensity has to be less than 100% or 100% of resting motor potential. In place of giving it at 120%, which is given in high frequency protocols. Okay. So it showed that around 86.4% participants had remission in open label study. This was an open label study. This was not a blinded study, and it showed that it is, but it needs to be replicated, and therefore it was approved. So this is what it shows. Standard F3 is blue, okay, and what they have marked is through their resting state fMRIs is given in red, okay. So they found that an average of 2.5 centimeter is something which is, the difference that they saw that, the DLPFC most anti-correlated with subgenual ACC and not the F3 position. Now, how long does the treatment last? How long does the response last? The durability of the response. So there are recent evidence which suggests that maintenance treatment should be given, and if given for an extended period, the response rate would, increase tremendously. Okay, compared to what would, a difference of maybe 20% response rate if you're continuously giving 20 maintenance treatment sessions. So this RCT, what it did was that it compared low frequency right rTMS as a maintenance treatment compared to lithium as a maintenance treatment or prophylactic treatment in depression, and they found that the efficacy was quite similar compared to the tolerability. Tolerability in lithium group was much poorer compared to the rTMS group. So it suggests that with maintenance rTMS treatment, if affordable for the patient, you can achieve similar rates of response. Now, the ways in which maintenance treatment sessions should be given differs in different ways. Some people say that you need to gradually taper it. Okay, 3 sessions in a week, then 2 sessions in a week, and so on and so forth. Some people say that after completion of the acute 30 sessions, you need to give one session a week or 2 sessions in a month, and you continue like that. So the guidelines have not specifically mentioned about how to go about maintenance treatment. So there are other disorders as well. So for anxiety disorders, high frequency of the right DLPFC in PTSD, low frequency of the right DLPFC in OCD, targeting low frequency over orbitofrontal cortex, low frequency over pre-SMA, high frequency deep TMS over medial prefrontal cortex. There is, yeah. So if you want to go ahead with anxiety disorders, low frequency to right DLPFC is the go-to, but you need to choose it on an individual basis what the patient is having. So in schizophrenia, it needs to be domain specific, not as a disorder. For auditory hallucinations, low frequency of the left temporoparietal cortex, and for negative symptoms, high frequency of the left DLPFC. But recent evidence also suggests that cerebellar TMS may be also a very good option in patients with negative symptoms of schizophrenia. Yeah. So in other disorders as well, substance use addiction, there is evidence for high frequency of the left DLPFC, which has been most studied. Some studies have also suggested their role in gambling and behavioral addiction. For Alzheimer's, a lot of studies have been done on high frequency over left DLPFC, but recent evidence suggests if you do a multi-site TMS targeting multiple areas which are involved in that particular person of Alzheimer's, specifically the frontal areas and the temporal areas, you may have a better response. But if the person is having a severe cognitive decline, then maybe the effect of TMS may not be as high as it could be in a milder versions of dementia. So high frequency to left DLPFC in substance use and Alzheimer's. These are some of the other neurological illnesses in which TMS may have some role, specifically Parkinson's disease, motor symptoms, and in stroke recovery. Okay. So the H coil, various protocols and the deep TMS coils, which are FDA approved and CE approved, okay, for neurology as well as psychiatry. So what are the takeaway points? Choose your patient wisely. If there are device protocols, start with those. So some devices have their own protocols. You can always start with those protocols. Some patients may respond better than others. Personalize your treatment. Don't go as is written in the literature. You need to personalize, but that would come with a bit of experience. First, you need to go what is written in the book, and then over time, as you gain experience, you may personalize your treatment. Stop benzodiazepines if possible, but it's not a necessary thing. Okay, because patient's improvement is the primary thing. So if the patient is not able to tolerate the reduction, continue with the minimum dose possible. Be mindful of psychosocial factors, be aware of different treatment protocols, keep testing motor threshold on a weekly basis, if not less. Okay. So that because motor threshold changes and it can lead to overdosing or underdosing of the stimulus. So if you're not able to see improvement, you can try accelerated protocols, you can try plasticity modulators like D-cycloserine, and you can always use priming protocols in which you can enhance the excitability of cortex through various priming methods. You can initially decrease the excitability and then shoot up the excitability, or you can stimulate the contralateral region of the brain and then through the corpus callosal pathway, it can induce changes in the excitability of the other region, and therefore you can induce priming in those people. So I think that was enough, and we can discuss more in the workshop. Yeah, thank you so much.
Thank you, sir, for such an engaging talk. The floor is now open for quick questions from the audience side.
Okay, I'll start the ball rolling now, if you don't mind.
Thank you, sir.
See, you've been running a center.
Yes, sir.
What's the incidence of epilepsy in your center, and what have you done to manage it if it happened?
In my experience, I have done at AIMS and I have done at my center. Till now, we have had only one seizure episode over the maybe 7,000 to 8,000 sessions that I have given under my supervision. And for that, in that patient, he was already on clozapine, maybe 350 or 400 mg, and he had some motor issues. So the first thing that needs to be done is rule out all the possibility that seizure can happen. Because we were in a tertiary care center, we were able to manage the seizure because we had accessibility to various things. But in a private center, if you want to be very careful, you can have a nearby emergency services available to you. Or if you want, you can if you have IV access or other access, you can use benzodiazepines, maybe lorazepam 2 mg can work.
Okay.
But I have not done it practically ever. Okay. Because there was no incidence of seizure, because we follow very clear guidelines.
No, is it a generalized chronic seizure or a focalized, or what kind of?
Can happen either ways.
So,
focal.
I also had one seizure episode when we were giving these. It started with focal, then it led to secondary generalization. Again, as he said, one patient was on clozapine, the other patient was on sertraline. So, like usually the documented literature, it starts focally, and they say that positioning, like a lot of other reasons could be contributing. But now with the neuronavigation and the actual coils actually move with the position of the incidences come down. The thing is simple lorazepam, like IV of if it is available for the second patient, that will be sufficient to avoid an attack. Then beyond that, like if it is in a tertiary care hospital, we can take the emergency and manage it. There is a very rare incidence, like people are scared.
That's the most problematic complication, isn't it? That's why I'm asking.
So in healthy individuals, the risk is almost negligible.
It's most feared, but it's
We are talking about a possibility, and
Possibility,
then
yes,
what
sir.
is done and how to avoid. That is the
Yes, sir.
issue I'm talking
I
about.
have not personally done it, but the literature says that lorazepam 2 mg may be sufficient for it. So
This is a practical question. What is the cost of establishing a center?
okay. So it all depends on where are you establishing, but for the machine particularly has a different costing. It can range from somewhere between 25 lakhs to maybe 1.5 crores.
So, as I've gathered from your lecture, unipolar depression earlier in the episodes, earlier in the number of episodes, and earlier in the treatment resistance, better will have a better result.
Yes, sir.
That's your point here.
Yes.
So, see, what happens is that since it's a costly process, not many people will be willing to
Correct.
be referred. So naturally, we're going to get patients only in the later stage of resistance. But when
Yes.
all other drugs have been exhausted, only they might come for a thing. In a good situation, you might not have a better result to show, and thereby you will not be able to get more things.
Correct.
Now, you said more sessions, better response, maintenance treatment, better response, isn't it?
Sorry, more sessions in?
More sessions initially during the episode gives a better response, and maintenance treatment maintains the response.
Yes, yes, sir. Yes, sir.
Is it cost effective?
So it depends on what it again comes to the patient's preference. If they are able to afford it, they don't want any side effects of the medication and anything, they can go ahead with it. But if largely patients who come to the centers are mostly treatment resistant, not responding to other treatments. So in those patients with a prolonged treatment, with a change of target sites, with combination of different protocols, combination of sites, so you need to adapt to the various situations, and then you can achieve a better response. But going ahead with a single protocol at the same site, waiting for response to happen, may give you a little less results compared to if you individualize the treatment.
That requires experience.
Yes, sir.
Okay, thanks a lot.
Thank you, sir.
If there are no questions, yeah, please.
Nice presentation, sir.
Thank you.
What about this role in case of addictions, various types of addictions? And especially they have mentioned like smoking.
So in India,
play
giving
role of
TMS,
smoking.
in India, giving TMS for smoking is a really difficult thing because no one is going to spend lakhs of rupees for smoking cessation. I haven't given specifically for smoking cessation in entire my experience till now.
What is your experience with other type of addictions? Then
For other type of addiction, specifically for alcohol, I have given TMS in maybe more than 15 patients till now, and in around 8 to 9 patients, we have achieved some benefit in craving. Although there are other contextual factors which play a role because they are coming in for treatment daily, they know that treatment is going on. Okay, so those also play a role, but definitely there is reduction in some craving which we observe through stimulation of either high frequency right or left DLPFC.
ideally, when can we suggest them this rTMS for
So
alcohol?
you need to manage the withdrawal. Okay, you cannot give rTMS in withdrawal. If you want to go ahead with rTMS in a mild withdrawal state, you need to be very specific about and motor threshold calculation. You need to start very low with motor threshold calculation so that the person does not have seizures. But till now, I haven't seen any seizure in patients who have mild withdrawal symptoms. But being on the safe side, you need to be very cautious when you are giving patients with mild withdrawal symptoms.
And how much sessions usually they require?
So again, the recommendation is saying 25 to 30 sessions would be at least required in the acute phase.
Yes, thank you.
Thank you.
There are two questions online. So the first question is
Sir.
probability of response.
Yes, sir. Sir, in your experience, have you noted any worsening of the symptoms, sir, in depression, anxiety, schizophrenia, psychosis?
So what happens with TMS is that there are reports which suggest that there can be an initial worsening of symptoms known as rTMS dip. Okay, because there is a disruption in the neural pathway that is happening. Okay. So don't get fearful of if there is a worsening. You need to psychoeducate the patient. Okay, and if the patient agrees with continuing the treatment, continue it for some more time. If the worsening continues to happen, then you need to change the protocol, stop the treatment, and you need to start thinking of some other alternative. But worsening can happen in the initial few sessions. But that's not a general rule. In most of them, it won't, but that's a possibility.
There are two online questions. One is about the longevity of response. So how long does the initial effect last, say, after 30 to 40 sessions? The other question is regarding how does it benchmark against standard established treatments like ECT? And considering the logistic and cost comparisons, when do you prefer one over the other?
So if there is so coming to the first question, the longevity of the response. So the response rates with and without maintenance treatment we need to see. So without maintenance treatment, after 30 sessions, maybe it would last for most of the patients with recurrent depressive disorder. Here I would talk only about recurrent depressive disorder, not a single or two depressive episodes in the past. In cases of recurrent depressive disorders, it would last somewhere between 2 to 3 months. The response rate would, the relapse rate would be somewhere between 40 to 50% in a recurrent depressive disorder. But with continued maintenance treatment, that relapse rate goes down to somewhere 20 to 30%. So comparing ECT and rTMS, if there is a severe depressive episode, a psychotic depression, the patient has to be admitted in most of the cases and needs to be given ECT, and there is a risk of anesthesia, and the patient needs to have significant wait time. There are more intolerable side effects with ECT, but very superior outcome compared to rTMS. So for a resistant depression, somewhere between 75 to 80% is the remission, is the response rate, and maybe around 50% or 40% is the remission rate with ECT. Maybe after 8 to 12 sessions of ECT, and whereas with rTMS, the response rate would be somewhere between 30 to 40% in resistant patients, and the remission rate would be somewhere between 20 to 25%.
There are some questions. Regarding D-cycloserine, you want to discuss about the dosage and
So I have not practiced, I won't be able to tell about it. It's just the literature that I reviewed and I was aware of it.
and regarding the when can we see the earliest response considering rTMS, dip, and all those factors? Is there a do you wait till the end of session or do you take a call midway?
So it has not been documented per se, but according to experience, there are only 3 or 4 patients that I had seen, out of which one had to discontinue rTMS session, and he continued maybe after 5 sessions or 6 sessions, they started developing this rTMS dip on an average, and we continued it for another 4 or 5 sessions, and they started showing improvement. And but in the other patient, we continued till 12 to 13 sessions, and there was still further worsening. We had to change the site of the stimulation, and with the change of the site of the stimulation and lowering down the pulses of frequency. So this was particularly auditory hallucination. After 1 hertz of auditory, so this is a case basis. Do not take it as a general rule. I stimulated the left TL temporoparietal cortex with 1 hertz frequency, and there was worsening of auditory hallucinations with that, significant worsening. So I tapered it down to 0.5 hertz, and with 0.5 hertz, the patient started improving.
Your clinical experience, is there any specific class of antidepressant when combined with rTMS has a good outcome? Say, for example, SSRI versus SNRI.
So I won't be able to comment on that, sorry. Class of antidepressant currently. But definitely, if there is a treatment resistance, you won't be sticking to the SSRIs. You have already gone up to SNRIs or TCAs. So we need to have well-controlled studies in order to comment on anything about it. I hope that is yeah.
There is a recent increased usage of ketamine that is of depression.
Yeah.
So very interaction between ketamine therapy and rTMS.
So recently, literature is coming up combined rTMS and ketamine, and there are various underlying neurobiological ways in which ketamine interacts with and augments. There are various methods through which ketamine can be, either simultaneously given before rTMS, given after rTMS. Ketamine started, then rTMS session given, and ketamine continued. There are various protocols which have been defined. There is something known as Square protocol, but I have not practiced ketamine and rTMS combined currently. So, as an experience, I won't be able to comment on that.
I think we had a fairly good session because there have been a lot of questions from the audience and online also. You got quite a good interest in the topic,
Thank you.
Shubham, and I really congratulate you. And with this, if there's no other issues, I'll close the session. Thank you very much.
Thank you, Dr. Shubham Naroli, for peacefully answering all the questions, and thank you, Dr. Rajkumar, for chairing the session. Now I request Dr. Rajkumar to facilitate our speaker.
Ask everybody to assemble. We say that session has started. Start.
I now invite Dr. Suresh Kumar to chair the next session on the topic neural navigation in rTMS hybrid mode. Dr. M. Suresh Kumar is an experienced consultant psychiatrist and director of Psych Hospital, Chennai. His areas of expertise include substance use disorders and addiction psychiatry, HIV/AIDS prevention and care, public health psychiatry, research methodology, and training. Dr. Suresh Kumar has led and contributed to several national and international research projects, authored chapters, and developed toolkits for opioid substitution therapy. It is a pleasure to have you as our chairperson for this session, sir. I now request sir to introduce the speaker, Dr. Rohit Verma.
Thank you very much. Indeed, it's a pleasure to be here this morning for a wonderful national conference on rTMS. I listened to the previous presentation and it's exciting to have presenters like this. Today, this presentation is also going to be on neural navigation, a topic which is very novel, and I myself is very excited to learn about it from Professor Rohit Verma. As I understand, neural navigation in rTMS is usually using advanced technologies like imaging systems to really have the coil replacement in a proper way. I guess, like that is going to be make it very accurate and reproducible and reliable. Typically, the conventional methods using the 10-20 age systems can fail in this accuracy. So I'll be very happy to listen to Professor Rohit Verma And I'm very happy to introduce Dr. Rohit Verma, mainly because I think he has mentored two of the speakers today, Dr. Rahul Ganesh, as well as, Shubham, have both been mentored by him. And also our own Srinivas Rajkumar has also been mentored by, Dr. Rohit Verma. So it's indeed a pleasure. We only wish you were there in Balaji with us to talk to us directly, but I think he's going to be doing it online. And he's currently the professor of psychiatry at AIIMS New Delhi. And he has an MD in psychiatry from the AIIMS New Delhi. And his special area of interest is exactly what you're talking today, is in the brain stimulation therapies, be it ECT or rTMS or TDCS. And I think he's also been very much involved with brain mapping techniques, and biological psychiatry is one of the core things he's interested in. I think he's been doing a lot of work on mobile technologies and cognitive testing. That's been one of the important areas in which he's been working currently. And his current role is an additional professor of psychiatry at the Department of Psychiatry, AIIMS New Delhi. And he probably, chairs the brain stimulation clinic over there, both the research and clinical services. And he's been interested in developing, as I said, mobile technologies and cognitive testing tools for patients as well as caregivers. And I think his professional membership, I think fellow and member of various national and international scientific bodies, and not, I think very rightly has been the former Secretary General of the Neuromodulation Society of India. He has co-chaired the Neuromodulation Subcommittee of the Indian Psychiatric Society. He is currently the member of the Award Committee of the Indian Psychiatric Society's North Zone. I think he's got a number of awards to his credit. His own ICMR thesis was supported by ICMR in 2005. Melvin Arts Foundation and Association of Parkinson's Disorders grant in 2011. And they all the Indian awards, big awards, Dr. B.B. Sethi Award in 12, Boral Award in 2014 and 2018, Dr. J.K. Trivedi Award in 2018. They've been awarded. And I think I also had received the fellowship award for the Y Mine Sao Paulo Advanced Science School in Brazil in 2013, and it's also received the Junior Scientist Award in International Parkinson Movement Disorder Society. Varied interest, I think deeply rooted to biological psychiatry, and I think a pioneer in India in neuromodulation work. Really, really happy to listen to you, Dr. Rohit Verma. Look forward to listening to you. I think it's going to be an exciting meeting. It's going to be a learning experience for many of us here, even as a novel topic that you've been talking about. Thank you, Dr. Verma, for your presence. Thank you.
Thank you very much, sir, for your kind words. I hope to do some amount of justice to that in this presentation. I hope I'm audible enough.
Yes, sir. Yes, sir.
Sorry, the voice is reverberating. Am I audible?
Suppose you can go ahead.
Sir, there is no
Thank you.
reduction. I am muting from our side. Your audibility is very good.
Okay, thank you. Thank you. I thank Dr. Srinivas and Rabu sir for inviting me to this conference. Neuronavigation, as sir has already mentioned, is a niche area in current trends of psychiatry. And it's working its way not just for neuromodulation, but it is also working its way into psychopharmacology too as well, but through other means. I'll talk about what neuronavigation means for neuromodulation, particularly from an rTMS perspective. So, over the years, just about giving you a little bit of gist about what was happening in past. As my previous two set of speakers have already talked about a lot about it, so I won't go into much details. But there have been a lot of trials which have been happening over the years, for the past century, and wherein scientists have tried to develop a machine which could be focused for a particular individual to cater to his or her problems of a nature which is in form of suffering from brains. But it was finally Dr. Barker who succeeded in 1984 and came up with this device which was safe, it was non-invasive, and was painless too. And therein began the era of TMS. However, with the best machines possible, yet we are not able to go much deep inside the brain. The cortex, yeah, it's very much focally possible to reach it, but the deeper cortex is what we are still struggling with. There are coils which are made now called as H coils, which some kind of companies, which give us the possibility to stimulate the subcortical areas, but they still are limited by the focality issue, because the more deep you go, the more non-focal you will become. So that part of stimulation is still what is lacking currently. When you have different sets of coils, like a circular coil or a butterfly coil, the geometry of these coils, they are the ones which determine the focality of magnetic field. Because what is happening at the end of the day is the current is flowing circularly in the coil, and the current, according to Faraday's law, is perpendicular to the magnetic field flux, and that flux which gets inside the brain and generates electricity back again in the neurons will depend upon the structure of the coil and the current flowing into it, and the focality will also be decided by that. And that is why the more larger coils will be less focal, and the more smaller coils will be focal, but will be only focal to a superficial extent, not for a deeper extent. So currently there are a lot of things which we talk about. There are single pulse, there are paired pulse, there are quadrupulse. All of them will have some amount of expected effect which we intend to see and want. Some amount there would be corrected effects, as the brain is a neuroplastic tissue, and the current that we want to be focused on a particular area will traverse to different areas too. And sometimes that may also lead to paradoxical effects on the contralateral hemisphere. So when one stimulates a particular region of the brain, and even with a focal thing kind of TMS or like high definition TDCS, that current will still diversify itself to various other regions of the brain. But one region would be much more activated as compared to all other regions. So that is how we understand the current neuromodulated techniques. So in TMS, or even for all neuromodulated techniques in that sense, hitting the target spot, what we want to stimulate, is the most crucial part of the entire story. Just like medicines have their dosages which vary, in similar way for TMS, it's not just the parameters which are important, it's the position of the coil to a particular area which is much more important. And since we understand that the coil positioning will be leading to stimulation of that particular cortical area, we have a lot of assumptions in our mind which will provide us with an opportunity to understand how much current needs to be delivered to that particular area, so that we can find a kind of a better result that we want. And for that, the primary assumption is that there is a uniform and constant seizure threshold throughout the cortex. So how do we localize the target spot? One is the age-old method, in which we utilize the 10-20 international EEG systems, wherein our scalp is divided into multiple areas, and utilizing the Bayesian, Inian, and the tragus points, extraocular points, we mark the entire surface of the brain with 10% and 20% differences. There are 10-20 systems, there are 10-5 systems, and there are even 5-5 systems too. So all these will give you precise localization approximation, which have already been reported in previous studies, which replicate whether or not the particular position of the scalp is deciphering a particular brain region, Broadband area or something other inside the cortex. So by that mechanism, we can utilize a particular scalp position to see where we are trying to focus the stimulation. So one of the commonest place to focally stimulate the brain regions, particularly for depression or negative symptoms of schizophrenia or cognitive improvement, is the dorsolateral prefrontal cortex. And the most precise position of dorsolateral prefrontal cortex is according to the 10-5 system called as FAFF3. But the 10-20 system will define it as in F3 area. The other method is what usually happens with all TMS machines, wherein you move a set distance along and across. So what we usually do is we try to find out a hotspot. Hotspot is something in which you stimulate the brain at the motor cortex, because you want to see whether or not you have been able to particularly hit the stimuli at the particular area. So the motor cortex, the motor homunculus, is where we can observe a change directly, instantly. So there are hand areas, there are leg areas in which we can observe a twitch. So by putting electrodes or EMGs in hands or legs, or by just directly visualizing a movement there, one can understand the motor hotspot on the scalp. And from this motor hotspot, you can calculate the dorsolateral prefrontal cortex as a reference point. So there have been a lot of studies done on this motor hotspot, and the presumption is from 5 to 5.5 to 6 centimeters of anterior distance from the motor hotspot of hand region is where the dorsolateral prefrontal cortex lies. So this is what usually happens in most of the TMS work which is happening around the world. The criteria is to have at least more than 50 microvolt peak-to-peak change of motor evoked potential in 5 out of 10 trials, when you start with at 50% or 35% of motor intensity of the TMS. The third method is called as a beam F3 method. It is only for localization of F3 position of the brain, in which you calculate the nasient to inion distance, the tragus to tragus distance, as well as the circumference of the entire head. And by feeding these three data into a online available software, which is free to use, you will get the position of X, Y, and Z as depicted in the pictures, and that will give you the localization of the dorsolateral prefrontal cortex. So at the F3 region, actually. And there have been various studies which suggest that this is somewhat akin to the presence of the EEG 1020 system based F3 localization. These are the three methods which are commonly in use worldwide, but none of them is a bullseye phenomenon. We have not been able to reach the exact localization. Why? The simple reason is that not all the brains are the same. And there have been studies done over multiple corners of the world, and which have over the years found out that all population of the world, they differ in their brain structure. Just like dactylography, all our brains individually are different in their gyri, sulci, and all the formations. There are even much more morphological changes between generation or societies like Caucasians and Africans and Americans and Chinese and Indians. They have all different sets of brain morphology. So there is a need for understanding a individual or a population specific morphologically targeted region which we can use. And therein is where neuronavigation comes. The word neuronavigation is primarily derived for stereotactic, which means three-dimensional touching. And in this form, one does a MRI of a patient first. And using that MRI scan, one can map the structural regions of the brain and then co-register it with the coil and then stimulate that brain region, so that one can be much more precise in their stimulation of the region whatsoever they are intending. This navigation is based upon targeting relative to known reference points. So when we say reference points, we are talking about fiducial regions, which literally means trust. These are points of reference which can be visualized on imaging, and they can be identified by the clinicians or even by the software packages. So the accuracy of targeting point will actually be depending upon the number as well as the constancy of fiducials, which is in relation to the target. So since 1906, we have been having this stereotactic frame mostly for neurosurgical, mostly for neurosurgeries. And in 1957, the first brain atlas was published by Taleric and Tolitz. And later on, we have been having many other frameless and framed brain atlases available with us. Since 1957, 67, and 88, Taleric and Tornox developed the first brain atlas, which was based on a single patient, a single French woman. So she was sliced off, and he was able to form a 2D map of an entire brain region. Subsequently, over the years, there have been development with not just a single patient, but more than one individual brains, and MNI 305 in 95, Colin 27 in 98, MNI 152 in 2001, ICBM 452 in 2003. They have been utilizing much more number of individual patients as well as healthy individuals to see the brain in a mean form. So the International Consortium for Brain Mapping is what all these are, they have all been utilizing still the Caucasian brains. From 2005 onwards, we have brain atlases from different regions of the world, Korean, French, Chinese. They've all developed their own atlases depending upon their own population, because they have found their population to be ranging in the weight, the spread, and the length of the entire brain for morphology as compared to the previous atlases. India has also not been far back in that story. And from 2017 onwards, we have 5 brain atlases in our country. The initial 4 were of a smaller population, but the 2020 HOLA one has a more detailed Indian brain atlas, which has comprised of 5 different sets of different age groups, so that one can precisely localize based on our population what the localization could have been. So when we target a localized image-based localization, the localization itself depends on the standard coordinates, which are based upon the position of the anterior commissure or the posterior commissure. Or one can just directly target the visually chosen area from the scan itself. The localization device is what the equipment is primarily needed. It may be optical, it may be electromagnetic, along with an articulated arm. One needs a computer with a software for registering the algorithm, and then one needs a effector, a pointer and a monitor. So for electromagnetic versions, which is common for neurosurgical operations, because there the patient moves about a lot, and then there are a lot of instruments which are there. So in that there is a fixation which can happen for the brain, so that the precision can be much more there. And they usually avoid optical, which is even much more better, because the instruments may hinder the optical pathway. The optical part is much more utilizable in TMS research as well as in clinics, wherein one can use infrared, which are the commonest way of utilizing optical localization paradigms for navigating the TMS coil. So what happens for visualization based on this kind of brain mapping format is, one loads a T1 weighted structural MRI scan, in which we prefer an isovoxel based format. These MRI scans are available in either DICOM form or a Nifty format, and both are okay in that sense. The accurate reconstruction of these brain surfaces and then unfolding, flattening, and all entire analysis is what subsequently happens. There is a surface reconstruction which happens, and then when we have this skull stripping problem, and then this there may be automated or even manual format of softwares available which can help you to solve this skull stripping problem. So what happens when we try to approach it is, we have a knowledge of a expected shape and range of variation of cortical envelope, which may be much more pertinent when we have a brain atlas of our own population. We have a module of voxel-based morphometry. We load a shape model, load MRI volumes, find a cortical envelope, mask the skull, find the cortical surfaces, use the guide to search for gray and the CSF boundary, infer the boundary where none is present, and then allow user corrections. So these all are done in steps, and they take a lot of time to master. But once you start doing all these things, they become quite easier to do. The automatic process handles all of them in one go, or based on the software itself, but the software may at times be required to be tweaked after the final result happens. But then it still is shorter in time and would take somewhere around 5 to 10 minutes for doing so. So what does one first do? When you put the T1 weighted MRI image into the software, it will give you the sagittal, coronal, and the axial plane for images over there. And you can select mid sagittal as the beginning point there, and then place the anterior commissure over there. And then you can change the parameters of the axial as the coronal slides, and fix the anterior commissure at the precise point. After the anterior commissure, then you fix the posterior commissure, and the posterior commissure again needs to be at the precise location in all the 3 slices. Once that is done, then you have to have a cortical bounding box. This box will tell the software where the cortex lies, or not the skull and not the scalp and other regions, but just the cortical part which needs to be there inside the box. Once that is done, then you have model fitting to happen. You can start segmenting. The segmentation starts on its own when you press the button, and after segmentation, it will give you a final segmented model, which you can then fit accordingly. If you find that there is some amount of gray white matter lost, then you can again distill back that into it. Once you have that gray white matter kind of differentiation, this segmentation model can be saved, and a final model can be rendered by removing all the errors. So all this is also helped by the software intermittently. You will get guidance about how to differentiate the gray matter and the white matter inside the software. Once you have that volume masking happening, then you can have that generation of a mask, which will compute the entire shell, the entire mask for the entire brain regions, and you can have your brain model ready for simulation, for identification of a simulation region. This entire process happens automatically also by the software by the press of a single button, but you may not get a very clear picture like what this currently is, and you may need to tweak it here and there intermittently to get the precise localization. And doing all this, you can get a final format of a regions where you can propagate and search for a target localization. And the target localization can be done then based on either manual localization, wherein you can utilize the pointers and put them on the certain region of the head, and the optical infrared device will tell you at what localization you are, and based on that localization, you can put the TMS coil, fix it on it, and then utilize it. Or you can have a automated TMS coil holder, which can also help out to adjust it according to the infrared guided navigation. There can also be computerized algorithm for using the entirely variant atlas, and the software can be fed by the brain atlas to what region one should go, and the coil would automatically be placed on that particular region. There are also cortical. These are structural based, where you have found a structure and you want to target the particular structure. But sometimes you would want a particular set of region to be stimulated just because the region is actively behaving differently. So when one uses functional imaging techniques like fMRI, FNIRS, EEG, you can get a different brain region which is activated, and you want to be focusing upon that region. So the software is also give you an opportunity to have the fMRI, EEG, or even PET-based data input into the software, which will be superimposed over the existing MRI image, and then you will get a particular brain region, wherein again you can position the coil and stimulate it as you want. Even with all this, there may be a lot of errors happening. The error could be an MRI image distortion itself due to slice thickness, pixel voxel size, or whatever. There could be spatial infidelity happening. There could be magnetic field inhomogeneities inherent in the MRI image, or there could be image fusions, which are common problems which can happen in an MRI image. The fiducial registration error can happen because of the image or the space axis disorientation. The algorithm can be ambiguous for that. There could be fiducial localization error, maybe because the number of fiducial numbers could be less, or they could be configured improperly, or they could be displaced by the clinician or by the digitalizer. Then there could be target registration errors, which can increase as a distance of target from the fiducial centroid will increase. Finally, there could be camera malalignment, and as well as the digitizer performance could have also been a problematic factor into it. So there could be many sources of error into this. That's why you need to recheck whether or not you have been able to correctly target and localize what way you were hoping to target for. Other than this, there could be another problem. There could be a constant and minute head movement. One cannot expect a human being to lay completely still without being anesthetized. We are not rocks. We always move about here. Maybe not to this much extent, but there may be a slight movement too. Even a slight movement will mean a centimeter of a loss in the particular brain regions. So when you are targeting a very specific focal area, you cannot have this kind of even minute head movements. So how to handle that? There are robots now which can help you to do that. They also help in coil positioning. They are also based on optical tracking and as well as marker based tracking. And as they have been able to compensate for these kind of head motion artifacts. So they will constantly detect and control the head movement and the coil orientation, and we will provide the coil to remain at a particular location for the period as long as you want it to be. So they help a lot in online mapping of evoked motor responses in that sense. This is our lab at AIMS, wherein we have infrared optical based neural navigation system. And at the back of his head, you can observe the robotic hand, which is being captured by the infrared sensor. There is a small digitizer on the head of the patient as well as on the coil, which is attached to the robotic hand. And the infrared captures that all in real time. And the software, which you can see in front, will be able to decipher where the coil should be localized. And the individual moves about here and there, the robotic hand will move accordingly. I'll just give you a small video on what currently is happening in this is one of the topmost kind of currently existing TMS machines, which has the robotic hand, there's neural navigation systems, optical based, all in place in the single machine itself. So one puts a tracker on the head of the patient, then registers the head utilizing a digitizer on different points. These are all fiducial points. Mark the scalp with the digitizer. The software will register these kind of paths, and it will help to position. The robot will then move about with the coil at the position that you want to. And then can begin the TMS session with the parameters that you choose from. And the patient moves, the coil will move along. One can monitor the entire simulation along. The software will give you that kind of an opportunity. And the entire session can handle it. So I think this is the best that is available in science of TMS neural navigation and robotics currently. I hope I've been able to instill some amount of thoughts into you. And future for brain solution seems to be bright for me. Thank you all.
Thank you so much, Professor Verma. I guess, really walked us through the neuro navigation in a very lucid manner. You started out talking about how this is fairly a recent phenomena. I think you talked about Barker in 84. At least three of the people here are classmates, Dr. Murugathan, myself, and Rajkumar. We passed out in 81 in psychiatry. I think we didn't even have a technique like this. And I think over the years, so much has happened. And we talked about the importance of focality, that's being very important, and how the coil shape actually will determine what exactly would happen, and the stimulation techniques and the spread of activation that happens in the brain, how we can actually localize it. And I thought hitting the target spot was brilliant. You typically we know about the three different methods of coil localization. One is using the 10-20 EEG system, which you're all very familiar with. The other one is, I think, localizing the hand area and then moving anteriorly 5 to 6 centimeters to identify the dorsolateral prefrontal cortex, which is the region of interest for more of us in neuropsychiatry, and also the beam F3 method. But I think you also said it's not bullseye. That really tells us the story of where we are actually in terms of accuracy. So you really talked about the individual variability in the morphology of different individuals. So it's very important to understand neuronavigation and to make it more accurate and reliable and reproducible. And you thought, like in neurosurgery, we are very familiar with the stereotaxic procedures and the frameworks and the brain atlas development that's been happening over a period of time. Dr. Bharat Phala from Nimans has done a lot of work in this. I think his brain atlas is now very useful. And you talked about the image-based target localization, and the optical one is very suitable for TMS. And I think how we can use the computer algorithms to target the area visually and then target it. I think not just the structured MRI, we can also use sometimes the functional MRI to understand some of the things. You actually talked about the source of error and how even a simple thing like a head movement can actually alter. I think this is very interesting to know how robotic things can actually control all this coil positioning. So a brilliant talk. I think even a person so illiterate like me could actually understand the whole process. And I'm really, really happy that you could make a very lucid presentation for us to understand. The first question I have in my mind is, it looks like it's a very sophisticated one. And I think, are you going to be planning this, navigation method for every single session? Can you make it more accessible? But I think, I'm sure MRI templates are available now. Can we use it and then, combine this coil position and this together and have it hybrid mode? And how would it be making it cost effective for the person who's consuming this?
Right, sir. Thank you, sir, for the kind words. You have summarized the entire presentation much better than me in less than a minute. The registration happens in the first instance, actually. When you're using a brain atlas, you need to do it only once for a patient, even though you have 10, 15, 20 sessions or even more. So that's the first session where you will be spending 15 to 20 minutes into registering that patient. If you have a personalized brain region for that patient, the software gives you again an opportunity to save that data. So even for the first session, you will have to register the entire thing process. And then for all subsequent sessions, it would be only a minute of chance there. You just need to put the data back out from the software and it will automatically register the patient and take the coil back over there. Even for the robotic coil. So the entire process will not take more than 5 minutes. The problem is that IT-based kind of sessions, they itself are less than 5 minutes. So you are there, and now we want to reduce the number of sessions from 30 minutes in standard TMS to T-based kind of session for less than 5 minute or 3 minute sessions. So that 5 minute of localization will add to it. So the session will increase from 5 minutes or 3 minutes to 8 minutes to 10 minutes is all.
The audience. Yes. Please identify yourself.
Come here and talk a little bit. Yeah, you can ask. Let's ask.
Good afternoon, sir. I'm Dr. Arjun Radhakrishnan from Kadagams. So thank you for the wonderful session. One thing I would like to ask is using a basic structural MRI, can we use integrate AI with this and use for the target localization so that most of these things will be done by the AI. So the process will be more faster and it can be adjusted according to the patient users. Just wanted to know the part of the AI.
Thank you, Dr. As I said in the last video that I showed, that actually is a kind of an AI in which you just tell the software where you want to go and it will do the entire job on its own. So you just need to handle that entire process for less than a minute and the machine will do everything for you. But these are costly affairs. These are not simple low cost machines like 25 lakhs or something, which Dr. Shubham and Rahul were talking about. These are high-end machines which go into crores.
So I think they are still in awe of your presentation. Is he there? I'm still in awe of the presentation. I think they are still absorbing the presentation that you made. It's actually a very, very novel topic. And I think I'm hearing for the first time on neuronavigation, anything like this for the first time. So stimulating for us and actually makes us to wonder how I think the future psychiatrists will be so much better off in using these technologies for the betterment of the patients. I think this is underutilized in this country as far as I understand. And I think we need to go a long way in rTMS. People like you and your students can actually take this knowledge to the whole of the country and make us understand that this is a very important technology. Neuromodulation is the emerging technology in the hands of the psychiatrists, which we should be utilizing. And for that, I think this kind of a learning platforms are very important. Thank you very much, Dr. Professor Verma.
Thank you, sir.
This is presentation.
Thank you very much.
We wish one of the days you come here and talk to us directly and stimulate us. Thank you.
Thank you for the kind words, sir. Thank you. I also hope the best for brain stimulation.
Thank you.
Thank you, sir, for the opportunity to learn from your experience, and thank you for answering the questions patiently. I now request Dr. Srinivas to felicitate Dr. Suresh Kumar for his valuable contributions as chairperson.
Thank you, sir. We'll proceed with other sessions.
I now request Dr. R. Rajkumar to introduce our speaker.
Thank you. It's my pleasure and honor to introduce Dr. Murappan, my senior, my classmate, my mentor, and my predecessor in many things academic. For a person who's finishes TPM in 81 and has been involved in practice, he has recently gained wide recognition and appreciation for his academic activity. He has, I don't want to go through his usual thing. He has published or presented papers in conference, has twice appeared for the prestigious Mahafati Award in Indian Psychiatric Society, and that tells about the caliber of Dr. Murappan. I would like Dr. Murappan to open the session. Thank you.
Thank you, Dr. Rajkumar, for the introduction. I thank the Medical College, Balaji Medical College, and the Department of Psychiatry for giving me this opportunity. We had a very nice sessions, and it was very enlightening and very informative for all. Especially the topics have been well covered by Dr. Subham and Rahul. And until now, there has been only one different source for anything on rTMS. That was Lafarge's. And that was giving almost all the meta-analysis of all the studies that has been there. And that was the only single source for anything on rTMS, but it was very outdated, 2014 to 18. Now we come out with a second model, second booklet, and congratulations to Dr. Srinivas for bringing out a very good manual. It is a do-it-yourself manual. And so it is very practical, and he has done a very good job. And I should congratulate Dr. Srinivas, especially for his work. Slide. Just a minute. I'll do just a minute. Right? You just have to change. Now we all know where to use rTMS and the indications, the science behind it, the basic mechanism, physiology behind it. But why? Why using an rTMS? Why not TDSS or any other thing? And here you find, because rTMS modulates excitability and neuroplasticity, and it by non-invasively, and regulates GABA and glutamate. And it as has been already told by Dr. Subham, gene expression, epigenetics, it plays a role in epigenetics, and also dopamine release. The main thing is about changing the inhibition excitation by imbalance. EA ratio changes. That is the main purpose we are using rTMS in almost all the psychiatric conditions. The problem is in excitation inhibition imbalance. So this corrects that imbalance. That is the main purpose of using rTMS. And it increases the gamma spiking so that it changes the cortical activity. And psychiatry is nothing behind physiology, neurology in action. Behind every thought, every action, every feeling, there is an action potential. We say we start with neurotransmitters. Neurotransmitters go back to brain waves. Yeah. Neurotransmitters, synaptic transmission, and synapse, and that go back to brain waves. Brain waves are, again, it is conductivity, connectivity, and networking, and these are the areas we ignore. So we want to correct this conductivity and connectivity and networks, and behind that goes excitation and inhibition. And going to the molecular level, it is depolarization. Depolarization is again action potentials. And everything psychiatry begins with the action potentials, change in the action potential. That is what we want to correct. And going one step further from action potentials is, what is the question? It is neural oscillations. If you can correct neural oscillations, you can correct a person's behavior, thinking, and feelings. And we want to correct the neural oscillations. And if you're going to invest such a huge amount, say for only one indication, say it has been say depression has been approved by only FDA approved for depression only, and it is not feasible. It is not practically viable to invest such a huge amount for one purpose, one indication, depression, and it is not, patient complaints is so poor, and it is not going to be viable. But why avoiding rTMS just for because of this investment purpose? There are other indications. If you are going to wait for FDA approval, it is not viable. And FDA approval doesn't come so cheap. It doesn't come so freely. And to apply for an FDA approval, it takes nearly $2.5 million. Yesterday, I had a meeting with a person from US working on exosomes, a step higher than stem cells. And he was telling that FDA approval, he didn't get the FDA approval. The reason was FDA approval, just to apply for FDA approval, it costs 2.5 millions. And getting the approval costs nearly 20 millions. Who is going to pay that money for getting an FDA approval? So instead of just because you are waiting for approval, you are denying this rTMS usage for so many other conditions. That is what we are going to highlight. What are the other conditions where you can use rTMS? And if you are going to say this is a win-win situation for all, if you are going to just depending only for depression and rTMS, many will not say the patient complaints is poor and the results are also not so exemplary. It is only 60% success. It is not all that rosy with rTMS and depression. It is not 100% success. Patient already comes with, you say, multi-drug resistant depression, but it doesn't respond. Even there, you expect only about 60% results. So don't deserve yourself only for depression. There are other indications. If it's not using the rTMS for these indications, you'll be busy, totally busy. Actually, your clinic image picture changes. And it goes into the, you have a lot of cases. Now you will find that there is an incidence of autism is very high now. When we studied 50 years back, there was no such diagnosis as autism. It was not there. It is only after the 80s it came that autism. Now autism is extensive. Almost you see every child, every family has got an autistic child or an ADHD child. If only if you are going to use focus rTMS for using on rTMS for autism, you will be busy. Your clinic changes into your pediatric psychiatry unit, and there is and with especially with autism, the patient complaints is so good. Parents are willing to anyway they are willing to spend the time and money, effort to make the child on. But that is not the case with the depression, because depression the earner is the patient, and they are not interested. The complaints is poor. When it comes to the child, patient parents are ready. So there is no dropouts. They complete. So autism is one area where rTMS is very helpful. And then comes ADHD. In every family, there is one autistic child or an ADHD child. So these are the conditions. We will see the details later. And I am listing the conditions here. This autism and ADHD. And then comes, so I found that MCI and dementia is another green area. There is, you get a very good response with dementia using rTMS for MCI and dementia. And there is a tendency among us that any case of forgetfulness, we name it as dementia. It is not. It is only MCI. These mild cases of mild cognitive impairment, that it is reversible. So in these cases, if you are going to use rTMS, the patients become better. These are the 4 indications what I use. Autism, ADHD, and MCI and dementia, and it is extensive. You are busy, and patients are happy, and there is a good response. And there are other conditions. Again, epilepsy. There is a fear that rTMS may induce epilepsy seizures. It is not so. We will see the responses later. And so epilepsy, it has been used. And these are conditions, schizophrenia, that is very famous, that was bread and butter of psychiatrists, maybe 50 years back, not now. And why rTMS? rTMS changes the excitatory inhibitory imbalance. Say there is a sensory and emotional social problems, and in ASD, it involves emotional function, executive function disruptions, cognitive changes, and memory and sensory dysfunctions. You will find, that almost all the autistic children, there is some kind of a sensational disturbance. Either they are very hypersensitive to touch, sound, or light, and it is only because of this sensory perceptual deficit because of the gamma disturbances. And again, I have found that the reason why the autistic children they have got these hypersensitivity problems with the touch, sense, and light is because they have been sensory deprived at the time of birth, perinatal. This has not been brought to light. So 50 years back, when the children were born at home or in a clinic, small clinic, the delivery process was different. Now, in the name of why autism has increased now, there is a reason. It has been reported. I tried to spoke to IOG, Institute of Obstetrics. I spoke to them to conduct a study, and also ICH, I told them to conduct a study, but they didn't come forward because it came from an individual, not from an institution like IMH. The reason why autism has increased now of late is because the delivery process. It is not any genetic factors alone. It is perinatal process in the sense, at the time of birth, in the name of avoiding infection, the babies are not touched. The babies are put onto the cradle. The babies not, though 50 years back or 70 years back, the babies were delivered immediately after delivery. The baby was allowed to lie with the mother, touching the mother. Now the sensory has been totally deprived. The babies are put in the cradle and brought to the say breastfeeding only as with the gloves. So they happen, and this baby loses the sensory touch and warmth of the mother, and every cell is an antenna that conveys, and you get this bonding. So it is the perinatal sensory deprivation leads on to these autistic factors. That is the reason they become sensory deprived, and it is because of this gamma is low. Gamma is required for perception. Because of the low gamma, there is a perceptual deficit. So that is the reason for you get a lot of deficits in sensory motor integration in autistic children. And in high functioning autism or in Asperger's, you find there is a cortical inhibition. It is on the end of, we can say that any autism is a connectivity disorder. It is not a developmental disorder. It is a neuroconnectivity disorder. We want to correct the connectivity. And rTMS improves the gamma. So sensory deficit becomes better. And when the gamma improves, irritability and repetitive behavior improves. And here you see one QEEG brain map. In autistic children, there is a lot of increased slow wave activity. See, it is all delta. You see delta everywhere. Delta is full. 1 hertz, 2 hertz, and 3 hertz. This delta waves, delta is full. And also alpha is less. Delta and theta are observed. These people, these brains, they have got slow brains. QEG brain map establishes these slow brains. There's a lot of slow wave activity in the form of delta and theta. And the coherence. Coherence is connectivity between different neuronal pools. Coherence is very high. And CZ, that is this area, again, dominant slow wave activity. The whole brain is full of slow waves. And there is high delta and low alpha ratios. And again, this is about connectivity within the autism. Long range coherence is high and short range coherence is reduced. And what is the protocol? This is not a protocol, no, it is not epithets written on stone. It is only a model. You develop your own model based on this. Individually, it varies. This is a common model, and in a reference in any scientific literature, you will find they will say it is inhibitory protocol on both sides. They will say most of these scientific literature studies show that is 1 hertz protocol on both sides. It doesn't work. So I tried this, and this I have this looks reasonably better. This works out, and you can try this. And again, it is you have to use the principle of excitation and inhibition. F3 we want to excite, and F4 on the right side we want to inhibit. So based on that, this formula I have given this protocol. And normally in almost all the studies you find, it has been limited to 15 protocol, 15 sessions. They say it is about 15 sessions. 15 sessions doesn't give the results. Even to know the, to see the difference, it takes at least about some 7 sessions. Only after 7 sessions, you see some changes. And say 15 sessions, what has been quoted in the literature or in the scientific studies, it is not adequate. I have gone up to 60 sessions of autism, and there is an improvement in the behavior. The mothers are the best, they report, they give a feedback report every day, and there is a changes in this by this protocol. About anywhere between 40 to 60 sessions works out. And there are other, say, other sites. And these are the other protocols I have been trying on it. Again, the same principle of using, increasing the excitation or reducing the inhibition, like changing the trying to influence both excitation and inhibition. These are the models I have been using it. And there is one more thing, say, one more site. I use PZ. This you don't find in the references. PZ is the area precuneus, and this has got very good effect on improving the memory and behavior. This is unusual. And again, when there is a speech improvement, when I want a speech improvement, it is individually planned. I use F7, Broca's area. Broca's area, I excite this 5 hertz, 5 hertz and 100 ppt and 60 trains. And again, another condition, ADHD. Again, it's a very common condition, but ADHD, the patient complaints is not as good as autism. Autism, the patient complaints is very good. At most, they don't drop out. ADHD, there is a volume loss in the brain, and also asymmetry of the posterior parietal cingulate, caudate nucleus, all these are involved. And with so much of neurological changes, you don't expect anything to improve with medical medicines or with the speech therapy or occupational therapy. Any autistic child, they say, I go to speech therapy or the OT. But how do you expect with so many neurological changes and connectivity problems to improve with speech therapy or occupational therapy? You have to interfere with, you need brain intervention. That is what we are attempting with this rTMS. It is direct interventional, non-invasive interventional to influence the brain function connectivity. And then again the neurological basis, neurophysiological basis behind ADHD is inhibitory control deficit, structural and functional changes in basal ganglia thalamocortical circuits. Again, EI pathway, excitatory inhibitory pathway, and there is low activity in anterior cingulate. These are the areas we try to influence in our protocol. Anterior cingulate, right, VLPFC, it is not commonly, it's not F3. It is between F4 and F8. The site between, it is not directly F4 or not directly F8. The site between F4 F8, we try to influence. Anterior cingulate, right, VLPFC and DLPFC, both. Causes inhibitory control and impulse control, causing executive function deficits. rTMS on the right side, commonly we say F3. For everything we say F3, but in ADHD, rTMS on the right side, between these two sides, influences the activity, where if you're going to counter side, left side, it should be inhibitory. Left DLPF is inhibitory. And attention deficit disorder in adults. Normally, we say it is adult attention deficit disorder. It is not ADHD in adult, it is ADD. In ADD, when there is less hyperactivity and inhibitory motor circuits. And what are the other areas involved in ADHD? Brain changes. Mesolimbic circuit is involved, ventral striatum, orbital frontal cortex, and working memory is involved. There is functional connectivity is affected, functional connectivity and EEG patterns. And there are other neurotransmitter changes, catecholamine and dopamine. And this low dopamine in prefrontal cortex leads to hyperactivity and irritability. We want to influence this low dopamine level. All the stimulants increase the dopamine. And these are all based on quantitative EEG brain mapping. This I have been doing that. Because of this, I have included that also EEG brain mapping findings. That is alpha and gamma are biomarkers in ADHD, those levels. And both are inversely, if alpha is high, gamma is low. We are conducting a study in Balaji here. We are trying to see the gamma levels in depression, assess the gamma level. That is our paper here. And gamma is, or alpha and gamma are inversely related, and then they reflect the cortical response. Somebody was asking about the response to TMS, and who are all the responders, who are all the non-responders, we can identify with the brain mapping. And these people, the alpha and gamma reflect the cortical response to TMS and the clinical and behavioral outcome. And again, the changes, neurological changes in ADHD. So because of all this, we are using rTMS. We advise rTMS in these conditions without waiting for FDA approval. And the ADHD protocols. This protocol has been working. That is high frequency of excitation on the right side, high frequency at the 18 hertz. Normally we will be giving 5 hertz or 10 hertz. Here in ADHD, this works out. 18 hertz frequency at repetition rate at 18, and PPT, pulse per train, it's 36, 2 seconds time interval, and total 1440 pulses. This works out in ADHD. And if you are going to combine this with atomoxetine, that gives better results. This protocol with atomoxetine gives better results in ADHD. It improves sustained attention, impulsivity, and inhibitions. And there is one more site, supplementary SMA, supplementary motor area. A stimulation of the medial prefrontal cortex has high frequency stimulation of the medial prefrontal cortex has the same effects. And on the other side, inhibitive protocol on the left side has a similar effects. Here is one more option. I have been using this option very much, and there is one more. Instead of 5 hertz, 18 hertz, we try with 10 hertz, repetition rate 10 hertz at 120% F3 left DLPFC pulses per train. But here it is 4,000 pulses, 20 sessions. It's another area. It is mild cognitive impairment and Alzheimer's. And what do you find in Alzheimer's? Alpha is low. Delta, you see delta everywhere. Delta and theta is everywhere, huge. It is diffuse. And all these people, MCA and Alzheimer's, they have got diffuse delta high. And Alzheimer's alpha is low. Immediately the first word we say is a slow brain. In a QEG brain map, when you look at an MCA case, we say this, the report starts with a slow brain. And this slow brain, the severity correlates clinically with cognitive changes. Lesser the alpha, cognitive changes are high. Alpha coherence in the midline is low. This was our study for the award paper. Predict dementia by brain mapping, QEG brain mapping. This was a study where it was found out that alpha coherence is midline is low and alpha is very low in the front. Again, for MCA and rTMS, Alzheimer's, the protocol, this works out, and I had several cases where this protocol was Wait a minute. Coming now? Yes. Okay. Not moving. Srinivas? Not moving. Well, Bola. Hmm. One second.
It's still either left, either right, sir. This is left. This is right.
So in MCI, we have for excitation use F3 DLPFC, high frequency at 10 Hertz and 40 pulses per train, 50 trains. Intertrain interval 26 seconds and total 2000 pulses. And for people with say speech difficulty, we add F7 Broca's area and additional site PC. PC is very very good for changing the mood, and because the PC precuneus is the responsible for responsible site for happiness. So out of the way we stimulate PC by PC at high frequency. The patient's mood changes. And stroke, especially after stroke, during recovery phase, after the acute phase, after 6 weeks, rTMS is effective to improve the aphasia and dysphagia. At this protocol, both contralational on the opposite side it is low. There is on the opposite side there is hyperexcitability, and on the same side it is in depression. So on the same side we excite, on the opposite side we inhibit. So this is based on that principle we have been using this protocol for aphasia and dysphagia. Opposite contralational is contralation because there is hyper excitability. We use low frequency dysphagia. It is all the choice between low frequency and high frequency, whether you want to excite or inhibit. Schizophrenia, as already has been spoken by other speakers, we use site TPJ, a site between C3 and T5. It has already been spoken by Dr. Shubha very well. Protocols for cocaine and addictions. And what has not been safety with the rTMS? I would say that seizure with rTMS is a myth. It is not. It has been reported out of 10,000 cases, 10,000 sessions, only 2 cases were reported. It was 0.01%. And even that 2 cases were already, they were prone for seizures, and the patients had got consumed alcohol the previous day, and there were other factors. So seizure with but this awareness is lacking. Seizure with rTMS, it is just a myth. You can ignore. We have not come across. In spite of, as Dr. Subham was pointing out, in spite of after several thousands of hours sessions, we have not come across. And maybe the one possibility of seizure is the intertrain interval. If it is shorter, probably it is likely to cause. So that is the reason. And again, seizure with low frequency is not there. Low frequency does not cause seizures. If at all rTMS causes seizure, it may be with a high frequency. And again, especially only that depends on the intertrain interval. So you pay important for the intertrain interval. Maybe if it is shorter, you are likely to, the person may be more prone. And maybe the only complication you come across, you will not call it a complication or side effect, maybe some discomfort on the first day, scalp discomfort or headache, and hearing loss. Again, it is only imaginary. It is not a common thing. These things we have to make. Say the seizure with rTMS is even nobody is aware. Even the neurologists are not aware of such a facility. I have had my own friends, very close friends, neurologists and HODs and professors. He was not aware that rTMS can be used for autism. His child was an autistic child. And so this awareness, if it lacks among the neurologists, say lack of awareness, say think of say among the common public, so we have to highlight that it can be used effectively.
Screen share ஆக மாட்டேங்குது. Screen share ஆக மாட்டேங்குது.
Oh. Will I move on? Please. And here is a ready reckoner. So instead of making all those measurements of and then making the calculation, this ready reckoner, it has been say included in your booklet, I think. So this gives the measurement. So based on this, you can just say locate your sites. You don't need a neural navigation system, and it is only maybe neural navigation is wonderful. It may be only for institutions, AIMS, JIPMER, and NIMANS, not for individuals. So for individuals, you can use this. And I come across one more thing. I use a brain map cap, QEG brain map cap. So it is a spontaneous. So otherwise, if you don't have a brain mapping cap, you can make use of this. So ready reckoner. And to use the sites, to select your sites, to make your own protocols, depend on, say, you don't get protocols everywhere for all the conditions. To design your own protocol, you need to know the site and functions. If you are aware of this site and functions, what site and what kind of functions you expect, probably you can design your own protocols. And here I have given the sites, giving 10-20 sites as well as Broca's areas in conjunction. And this is included in the booklet individually. These are the other sites. Again, comparison here. This pictorial is presented in a Word format in the booklet. This format is there in the booklet. So you can choose the function and select the site. And there was a question about responders to TMS. How do you identify the responders and non-responders to TMS? Here you find those who have got this again based on QEG. Those who have got a high RTM alpha on the left side, they respond well. So you can choose the kind of patients for whom you can suggest rTMS. Response to rTMS can be predicted, right? Frontal alpha asymmetry and shift of frontal alpha asymmetry towards right. Right frontal alpha asymmetry predict good response. So for this, you need QEG brain map. Again, responders to TMS, they got low alpha 2. And pretty these are areas F3 on the left side. And again, response to ECT, what kind of because again, I noticed that the response to treatment is poor and failure is, we say very common failure is very common, or the multi-drug resistant. It is not because the patient is not responding, because we are trying to treat a trait with a state. We have not identified whether it is a depressive state or a depressive trait. And maybe the failure, so much of common failure common with the treatment is because we have been trying to treat depressive trait. Maybe you identify whether it's a trait or a state. It is possible with a QEG brain map. Again, non-responders to TMS. Again, the morning question. Low positive alpha. Normally, alpha should be high in the back and in the right. What happens with the depression is alpha becomes less in the right back. So the low alpha is a poor response. Low positive alpha or non-responders. And again, there was a question about age. So my youngest patient has been 4 years. So rTMS has undergone nearly about 15-20 sessions or more, and the youngest patient is 14. My mean average patient age is around 7 to 11. So it can be used in all ages safely. And there was another question about insurance. We have made an effort to so that this insurance claim is possible. So we are the first one to get rTMS treatment is eligible for insurance claims. So it is not a problem. You have to make it accordingly. And non-respond protocols, and cap measurements. So there is a standard cap is available, a brain map cap that you can use it, and ready record and treatment field and responders, and the schedules are. And again, it is not very schedules written on stone. It is flexible, and almost rTMS therapy is a flexible schedule, and it is not necessary that it should be on 5 days a week. You can make it say that suits your convenience as well as the patient's convenience. It can be alternate days or twice a week or thrice a week, and it can be extended. So nothing is fixed. It is totally flexible. And with so much of convenience, the patient complaints will be certainly good. So these are all the conditions you try. Just remembering what to excite or inhibit, where to excite or inhibit, stimulate. You can devise your own protocols for any chronic conditions. Certainly, even if there is no complete improvement, total recovery, there is an improvement. Behavior changes. Patient feels better. Yeah. Yes, I complete.
Thank you, Dr. Murpan. I have quite a few comments. I would make them first and ask for listening from the audience, if you don't mind. Dr. Murpan's treatment approach and the presentation is definitely not mainstream. It is definitely not mainstream. I want to use the word revolutionary, but then I thought I'll compromise myself with unique and novel approach to the field of rTMS. Since he has experience in QEAG, he has also combined this, which has not been done. Now, what Murugan has deviated from your mainstream indicators is about age in the first place. It's less than 15, you've gone to 4 years also. Okay. And about next about the conditions. You've attempted to give rTMS for ASD, ADHD, MCI, and sorts of conditions. Is it in the books? Is it and the issue is that when you started to give rTMS for these conditions, what is the theoretical reasoning or logic behind this attempt? These are questions I have for you.
That is the electrophysiology I have given. Yeah, already I have given I started with giving the electrophysiology happening in the particular conditions. Based on the physiology only, I try to change it. And there have been some references of these studies, these procedures being done on these conditions somewhere.
It's been done.
Has done it.
Okay.
And there is it is available in the literature.
Thank you. I didn't know that. That's why I wanted to ask you.
It is available.
Thank you. Now, can I have feedback from Shubham and Rahul about this paper, please? You have any comments to make?
So I think presentation was really novel for each and every one of us because these are some of the different kind of approaches that I got to know today. Maybe I can go back and read about them more and maybe we can, to whatever extent possible, maybe we can see how well we can establish it into our own practice. And I would definitely like to talk to you more about all this.
Sure.
There are a few questions online. Rahul Singh has asked the minimum age child can be administered rTMS for autism. Then again, one more question: how do you ensure the delivery of rTMS while the child is moving?
When the child is?
The child keeps moving around. Child keeps moving around. Child not be. Child is moving around. So the child is moving around.
So the difficulty will be there, and the program does not continue. We break and do. And when the child moves, it is paused, and then again hold and then do it. It may not be so perfect, but there will be some compromise.
Yes, please. Sir, as you mentioned, sir, I am Dr. Chandrasekhar from Miraj, Maharashtra. Sir, as you mentioned, its role with atomoxetine in case of autism. So, I would like to know about anti-craving drugs and this rTMS. About your experience.
About which stuff?
Anti-craving drugs in addiction.
Craving.
As you mentioned, cocaine.
Yeah.
And alcohol. And would like to know something about brown sugar, opioids.
Yeah, same formula. Same protocol. Yes.
And the role of anti-craving drugs, which one is better? rTMS with anti-craving drugs combination.
And rTMS.
rTMS.
Yeah.
Any other questions or contribution from the audience? Since there are no questions, I will conclude this session and thank Dr. Murugan profusely for.
Any comments from Suresh?
So I think thank you very much. Always been educative listening to you, Dr. Murugan. Very similar to your concept. There is a neuromodulation center which actually established by a US psychiatrist in Chennai and uses very similar technology of using QEEG, understanding the EEG patterns, and then actually then provide personalized TMS to primarily children with lived experience of autism spectrum disorders and attention deficit disorders. I think it's been operational in Chennai for the past 2 years. And I think in the past 2 months, they are trying to move to Bangalore, to Kadapa. I thought somebody is Kadapa, I think Pete, Karma Pete is going to move to your center. So they've used very similar technology. I think I've been in close touch with them. And I think they've had tremendous success with tremendous improvement with children with autism spectrum disorder. They also recruited very young children. So your thoughts very much echo with what I've actually learned from that center in the past 2 years.
Sir, good evening, sir. Sorry, good afternoon, sir. Sir, as it was mentioned in previous lectures, even minute head movement can displace the target to several centimeters. What if you combine anesthesia induction with rTMS? So, as you have said, even to 4 years child, you're given rTMS. That's why I'm asking. So it's not easy to control 4 years old kid, right, sir?
But the thing is, No, the program what normally takes 10 minutes, with a child, such a small children, it takes 30 minutes. You have to break, pass, and so many pass. And it's not a continuously, we are not going to, we cannot administer 10 minutes. So we pass every few seconds pass and then continue. Takes longer time, maybe more effort on our side, takes a longer time. Maybe anesthesia, giving
So in
anesthesia.
previous lecture that doctor have he has emphasized that anesthesia being induced with rTMS. That's why I asked.
How far it will be viable, I don't know, but we cannot think of that.
So there is a small doubt, sir. So currently we are following MHCA in every mental health establishment, sir. We are using novel ideas to use rTMS in children's. How MHCA and rTMS in children, any interlink or any loopholes to come out of that legal aspects?
MCI?
So Mental Health Care Act is established in every mental health establishment, sir. Our novel ideas is to use rTMS in child cases like autism, ADHD. Is there is any mentioning about those non-invasive technique in MHCA, or there is no such things?
Very unlikely, because rTMS itself is a new technology, and whether they would have included, only Dr. Suresh or Rajkumar can say that.
No, I think one thing, ECT, the only thing that predominantly gets mentioned in NCA, I think they strongly recommend modified ECT. But anybody who's an adolescent or young person, who's going to get the modified ECT, it should be reviewed by the board. That's all it's saying.
Mental Care Act, Healthcare Act and children involvement, it's a slightly a gray area actually. We cannot say with conviction that it is possible or it is not possible. I am not very much aware. And in a establishment where the parents bring the child, it is an implicit consent in that. And in loco parentis, that is, the parents give the consent for the child, and that should be okay for any treatment process, especially a non-invasive treatment process. Only when it becomes an invasive treatment process or something severe as ECT, then the questions are different. And these are non-invasive procedures, so it should not be a problem in my opinion. Thank you very much. No, I think that concludes the session. Thank you very much, Dr. Muraban, for an enlightening lecture. I was really educated by your lecture. Thank you very much. Again.
Thank you, Dr. Murugathan, for your engaging talk. I now I now request Dr. Rajkumar to kindly felicitate Dr. Murugathan.
No. We are classmates. Classmates, so we would like to be together.
They are from 79, 81. Such a pleasure.
It's Dr. Suresh Kumar to felicitate Dr. Rajkumar. Now we'll be moving on to the live demonstration.
In the center for the plasma, we can show in the webcam. Take this paper. We have you see how the each police was very
Mission prevention. Oh, we'll have a patient with me.
Yeah.
வந்துரும் இது வருமா வெப்கேம் மைக் மாத்திரலாம் யா இது வராது அவ்வளவு தூரம்
Ready.
He also come in details.
Arey, we had an intern, no, was perfect head shape. Where is that intern? Rahul. Arey, where is the intern? How is it? View is good. Like this. Okay, perfect, perfect. Who is the subject? Very excitable. Anup, come on, sit. Yeah. Sit. Go through Sunday on the sir. Mics. You have to use the mics. Yeah, we can keep it. No problem, sir. You clear what I No, we didn't. You are streaming this. You stream also? Yes.
Glass also.
Leave. Cap, skull cap.
Marker skull cap measuring tape.
Marker skull cap tape. Okay, where is that? Mary sister. Marker skull cap tape. There is a set of everything depends. Here you can start explaining. Generally, you can introduce the machine. What is the diagram? What we are going to do.
This is MacVitch's R20 machine, and this is air cooled. And there are two methods: air cooled or oil cooled. Air cooled machine, they have got limitations. So it reaches you cannot use it indefinitely for infinitely, and there is a restriction. The temperature increases, and then when the temperature reaches 42 degrees, it goes off, switches off, and then you have to cool the coil and then again use it. You have got continuous number of cases. Probably this may not suit. Keep everything. So you need some device that where you can use it continuously. This maximum you can one day you can use about 8 or 9 cases. One day about 8 to 9 cases you can use sessions. So with this, the limitation is again the coil. This coil it is not infinity. It is only a limited number of coil pulses. This coil comes for only 5 years, and total 18 million pulses. Whether you use it or not, every day the coil loses its life. Every day it becomes less. Even in case you are not using it, at the end of 5 years, the coil stops. You have to replace the coil again at the cost of nearly about 6 lakhs. The coil alone, not the device. The coil alone, 6 lakhs, you lose it. So these are the limitations. Again, but here you get the coil number readings, pulses reading. With every session, you note the pulses, how many pulses you are given. And that is the advantage and disadvantage with this kind of machine. But this is the model that US FDA approval has given for changing this MacVentures, this coil, all those things. But there are some other programs where the machine is not listed. So we are going to use this machine for locating this RMT for spotting out. Okay. And I was telling, see, normally there are so many methods. Measuring with the tape that is commonly available everywhere. It takes from neon to neon. Now Dr. Shubham is making the measures neon to neon. You need to take three measures: neon to neon and circumference and tragus to tragus. Three measurements. Neon is the most prominent part in the occipital portion.
36
No
centimeters.
doubt.
36 centimeters.
How much?
36 centimeters.
36. Okay. And tragus to tragus.
39 centimeters. So the cross section would be CZ.
And where they cross, that becomes a CZ. Where the lines intersect, that is a CZ, central streak. How much?
58.
58.
We enter all these parameters into the BMF3 software.
BMF3 app will be very useful. Just to look at F3. You make all these points and it gives the F3 where it comes.
So for example, if the BMF3 shows from the neon to laterally, the measurement is 6 centimeter, and from the CZ the measurement is 10 centimeter. So first we laterally will measure point from the place it in the midline and you go laterally and you
No problem.
I can do it on the right.
Yeah.
So
You are blocking the view of the camera.
yeah.
You hold the knife.
I don't know. So you go laterally, either right or left, whichever DLPFC or F3 or F4 you want to target. So laterally could be 6 centimeters from the neon. You mark one point at 6 centimeters, and from CZ. So this gives you an angle. The angle at which you need to mark the 10 centimeter. So here is 10 centimeter. Okay. So roughly somewhere here you will get the DLPFC.
When you make these three entries in the BMF3 app, it gives you the reading. That readings you apply. That it gives a reading of F3, but if it is 36, 3.6 from any point, 10, 10, 20. So 1.8 here it comes up. So it will be one finger above this eyebrows. 10, say roughly about, say your line starts at this equator line starts one finger width above the eyebrows. So that is 10%. At this 10%, again 20% from here, it comes somewhere around, it will be about 5.6 like that. You can check up that whatever the F3 gives. And from here to CZ, that cross line. From here, from CZ, you bring the line here, and wherever the point F3 comes, that is the reading. You note it down, that becomes a F3. Is that clear? Or you need?
Anyway, we'll explain this
F3
again in
we
the
can-
afternoon session, and you also have the handbook which has all these regions and details
So
mentioned.
measure the motor threshold. of
F3,
Yeah. We'll
app
start motor
open.
threshold.
F3 app open for me.
No, we'll finish it off, sir. That we'll do it in the afternoon.
Okay, the F3 we will show during the afternoon session. And then now,
If we just demonstrate the motor threshold.
motor threshold, we start with intensity of 50. That is what the motor threshold measurement starting is. We start with a 50%, and also we are going to see the stimulation of this abductor pollicis longus on the right side. We're going to simulate left, and we see the response on the right side, right abductor breathing longus. And we are going to stimulate at M1, motor area 1. That is actually motor area 1 is 1020 point is C3. So we are going to simulate C3. And the coil orientation is important. Coil orientation should be 45 degrees angle to the midline. If you are going to simulate, give one stimulus at 45 degree angle holding the coil, and you should get the response at least 5 out of 10 times. And the stimulation time gap should be at least 2 seconds between one stimulus to the other.
So do you want to hold the position?
Device enabled. Start. Protocol paused.
Now we are giving a test stimulus. T3. T3, you know the T3.
So I'm taking a instruction from
CZ.
CZ to maybe 5 or 6 centimeters. 5 centimeters lateral.
Yes. Look at this angle. The way he holds the coil, it is 45 degrees angulated anterior posterior. The direction is important because the wave travels along the brain waves. So usually, if you are going to reverse it, the effects will be different. Change. So we go. It is only anterior posterior. Go holding the coil.
Yeah, you can see the twitch in his hand. Do it again.
You must tell the person to hold the hand like this. Now see.
Yeah.
Did you notice? So his RMT is 50. And in case if it doesn't come, we increase it to 55, 60, like that. Normally for many it works out at 50, 55.
Yeah, you can keep it down now.
And you must know what it feels like. Before we giving the patient, we must know what it feels like. That you can test it. Test the check. That is the feeling you get. Some kind of a pulse. So we had to convince the patient it's not going to cause harm or hurt anything. It is only the click. This is the brain mapping tab I have been using. So there is no question of these measurements. And the skull size does not vary with the age. Say after the age of 6 to adult, it is the same size. That you need about some 2 caps. Even this one cap is enough. Almost you put on, you get all the points. PC, what I am telling PC and also SMA. SMA, you don't get it on the map. SMA, you have to mark. And SMA is a very useful site. Mainly, we get a lot of patients with obsessions. See, continuous thinking. People say that I am not able to forget. All those stuck cases, SMA is very useful. And this you don't find in the literatures. SMA can be used for so many, it is very useful, especially in almost all these patients with all the stuck states. So SMA, you have to mark it. SMA is just about 2.5 centimeters before the seizure. All the sites are marked here. It just fits onto any skull.
It's a pretty simple technique. It's not a very difficult thing to do, and with practice of maybe 4 or 5 days, you'll be as good as us. Motor threshold calculation. The difficult part lies in protocol decision and patient selection.
Protocol, you develop your own self. When you understand these basics, you will be able to develop your own protocols. That is very effective.
Any questions? I think we'll have detailed discussion in batches with the trainers. So now we can break for lunch. Thank you, sir.
Thank you, sir, for the demonstration. We'll break for lunch.
Thank you all the online participants. Now we are breaking for lunch. Thank you.